Hi everyone and welcome to this session with me Dr. Vaishnavi. So we're going to discuss the MCQs that were given in the INI-CET mock examination. So we'll go one by one and we will understand the questions. The first question here is of a 4-year-old boy who's presenting to you with a sudden onset of high-grade fever, sore throat, drooling and rapidly progressive difficulty in breathing. So whenever we think of 4-year and we're thinking of a high-grade fever, and along with that they have told you that it is an inspiratory type of stridor. So we've learnt a thumb rule, a boy, a young child presenting to you with stridor, with digestive symptoms like dysphagia or dinophagia or drooling of saliva, and along with that if the patient has got no voice change or very minimal voice change or no cough, then we think about epiglottitis. Now in epiglottitis we see a position which is called as tripod position. They have told that this child is stabilized in the operating theatre, which is the best way to manage the child, with facilities for intubation, because if you try to do anything the child will cry and crying will only increase and aggravate the stridor. So the best way to manage this child would be in an operating room with facilities available for intubation and tracheostomy, and exactly that has been done. And an X-ray is performed. What is the most likely sign? So they have given you an entire learning MCQ where you know the symptoms, you know the signs, you know the position, you know the treatment, you know everything learned from the MCQ itself, but they are asking you one very simple question here on what sign do you see. So in a patient with acute epiglottitis, the sign that we see is called as the thumb sign, which is seen on a lateral view X-ray. We do not examine children with epiglottitis. We just take an X-ray, and if thumb sign is positive, then we know it is epiglottitis. Steeple sign is seen in patients, those who have laryngotracheobronchitis or croup. Bull neck sign is seen in diphtheria. And there is nothing called as water bottle sign, but there is a bag of water which we see in Rinke's edema. So with this, I'm sure you've understood the first question. Let's move to the second question. A patient with laryngeal cancer is planned for total laryngectomy. So they're telling you that a patient is planned for total laryngectomy, in which the entire larynx from the hyoid bone to the pre-epiglottic space, the strap muscles of the neck, the trachea, all of that are removed. The trachea is brought out as a permanent tracheostomy and the pharyngeal wall is repaired. So they're given you entire surgical steps that you perform for total laryngectomy. So again, this is a learning MCQ, and they have now asked you what is the indication. So the question is very simple. What is the indication for total laryngectomy? So even if you didn't learn or didn't read the entire MCQ and went just to the last line, you could still understand what is the question prompting to you at. But yes, since you have read the question, you've learned what are the structures removed in total laryngectomy. So when we are doing total laryngectomy, what is an indication? So whenever there is a patient who requires total laryngectomy, which is a gross or a very morbid procedure, the indication has to be advanced. So advanced stage 3 and 4A, 4B cancers, if there is any invasion of thyroid, cricoid or any cartilage, if there is a bilateral arytenoid involvement, then you're going to go for total laryngectomy. So in a primary patient, not about recurrence, so in a primary patient who's having bilateral arytenoid involvement, if there is a patient who has involvement or invasion of cartilages like thyroid and the cricoid cartilage or the epiglottic cartilage also, and if there is an advanced stage 3, not early stage 3 but advanced stage 3 or 4A or 4B, then you're going to go for total laryngectomy. Now we've learned that if there is a patient with stage 3 or early 4A malignancies, we go for chemo-RT. So fixed vocal cord in a T3 lesion is not an indication for total laryngectomy. If it is only fixed, there is no invasion of cartilage, there is no invasion of spaces, then we do not go for total laryngectomy. Cricoid cartilage invasion is definitely an indication. Small superficial glottic tumor again is not an indication. So the correct answer is option 2 only. So the correct answer had to be option 2, which is not given here amongst the options that were given here. Fixed vocal cord is not an indication for total laryngectomy. If you have a patient who has fixed vocal cord with involvement of the thyroid, cricoid or the arytenoid cartilage, then you will go for total laryngectomy, and the arytenoid involvement also has to be bilateral. If it is unilateral arytenoid involvement, then you will go for near total laryngectomy. So I hope this question, which is a little not so right options question, is sorted for all of you. We have a question here on a 45-year-old woman who reports recurrent episodes of vertigo. So whenever we have vertigo, we've learned that we're going to identify the answer based upon the duration first. This is lasting for 20 to 30 seconds. So now we know minutes to seconds is going to be BPPV. Again, it is triggered by changes in head position, prompting us towards the diagnosis of BPPV. So now we know very clearly that this is BPPV. Dix-Hallpike maneuver produces vertigo and rotatory nystagmus after a latency. All of these are very diagnostic of BPPV. Now, what is the most appropriate treatment maneuver? So we know for BPPV, benign paroxysmal positional vertigo, the treatment is nothing but canalolith repositioning maneuver, also called as Epley's maneuver. So that is what is given in option A. Beta histine for vestibular neuritis is not the case, because in vestibular neuritis they have a single long episode of vertigo lasting for days and sometimes even weeks, but it is not like vertigo lasting like this for a few seconds. So that's gone. Diazepam is again not an option because this is a benign condition. It is not requiring anything like a sedative to control the vertigo. MRI to rule out central pathology is not the case because there is a vertigo after latency. Central vertigos do not have latency, but peripheral vertigos do have a latency, which is what they have given in the question, which is why we know the diagnosis is for sure BPPV, and for that you will do the canalolith repositioning maneuver. Now let's go to the next question, where an 8-year-old child with a history of recurrent otitis media presents to you with hearing loss. So there is an 8-year-old child, hearing loss, but there is no pain, there is no fever. Right here the air conduction is at 45 and the bone conduction is at 15, which means there is a air-bone gap, and when BC is normal, AC is abnormal and there is an air-bone gap, we think of conductive hearing loss. So right side there is a conductive hearing loss. On left side AC is at 40, which is abnormal, BC is at 10, which is normal. So again AC abnormal, BC normal and an air-bone gap again tells you that there is a conductive hearing loss. Tympanometry is showing to you B type of graph bilaterally, which indicates that there is a fluid in the middle ear. So fluid in the middle ear without pain, without fever in a 8-year-old child with conductive hearing loss, you know the diagnosis is bilateral serous otitis media. Have they given you any underlying feature of adenoid hypertrophy which is usually seen in children in an 8-year-old with bilateral SOM? No. So we are not going to think about adenoid in such a question. Now we are going to only think about what should you do for bilateral SOM. So bilateral SOM, the initial management is wait and watch for 3 months. After 3 months, if there is no resolution, then we are going to do a surgery which is called as myringotomy with Grome insertion. So the correct answer will be myringotomy. Instead of Grome, they have used the word tympanostomy tube. Tympanostomy tube or a Grome would mean the same. So that will be the treatment. Hearing aid as a permanent solution for SN loss is wrong because this is a child. There is no SN loss. There is a conductive loss. Mastoidectomy for chronic otitis media with effusion? No, because this is not, mastoidectomy is never required for patients with SOM. Stapedectomy, the clinical scenario of bilateral conductive hearing loss can be in otosclerosis, but the age will be different, 20 to 40 years, female patient, and you would see AS type on tympanogram, not B type of tympanogram. So now we are justified with our answer, which is myringotomy plus Grome insertion. A 45-year-old woman undergoes total thyroidectomy for papillary carcinoma. Post-operatively, she develops perioral numbness, muscle cramps and a positive chopstick sign. Serum calcium is 7.2. So this is suggestive to us of hypocalcemia, which is a complication that happens following thyroidectomy if there is an inadvertent removal of the parathyroid gland. And whenever you have such a patient, you have to give intravenous calcium gluconate administration because it's absolutely essential that you immediately reverse the hypocalcemia. If you repeat the calcium measurements or your parathormone measurements, it is okay, but immediately if somebody has a positive Chowstick sign, a calcium level of 7.2 with perioral numbness, you can't wait for 24 hours and then start the therapy. Oral calcium carbonate and vitamin D supplementation are not the treatment option in an emergency situation like this. Recombinant parathermone injection is again not an option. So the correct answer will be intravenous calcium gluconate administration. A 35-year-old male presents with a 12-day history of nasal congestion, facial pain, and purulent nasal discharge. So, this is a 12-day history of facial pain, nasal discharge, and nasal congestion. And CT of the sinuses shows to you that the maxillary and ethmoid sinus, there is an involvement with air fluid level. So what is the most appropriate antibiotic therapy? So this is a scenario talking to us about acute maxillary and ethmoid sinusitis. Again, in an acute patient of sinusitis, we generally do not do a CT scan unless there is a possible complication we expect or the patient is immunosuppressed. Only then we are going to think of doing a CT scan. And in acute sinusitis, where there is a disease of only 12 days duration here, we would never recommend in a real life situation. But if the examiner is trying to prompt you towards the diagnosis of acute maxillary and ethmoid sinusitis, they have given you the finding of CT. So whenever we think of acute sinusitis, the organism is most commonly Streptococcus pneumonia, and the treatment of choice will be amoxicillin with clavulanic acid because that's the drug of choice. Azithromycin, ciprofloxacin, cephalexin are not the drugs of choice for Streptococcus, although they may be given, but the drug of choice tends to be amoxicillin with clavulanic acid. So with this, I hope your ENT questions are sorted and all of you have been able to solve these questions right in your exam. If there's any problem, do reach out to me. I'll be more than happy to help you all. Take care and bye-bye.
A very big hello to all my dear students. So let's discuss the ophthalmology questions here. Your first question is a 70-year-old man with atrial fibrillation presenting with sudden painless loss of vision. Heart problem, sudden painless loss of vision, right? The slide or the clinical finding is in front of you. I think you are already there. We are talking about central retinal artery occlusion. Okay, so let's read the whole question. Painless loss of vision in the right eye lasting 2 minutes. Visual acuity is reduced to hand movements. A relative afferent pupillary defect is present. Fundus examination is shown below, and what is the most appropriate immediate management? Right. So, what is the immediate management of central retinal artery occlusion? What you are looking here is cherry red spot. We all understand this. So, this is your cherry red spot, and yes, this is a case of diagnosis is central retinal artery occlusion. And what is the first step? We have to decrease the pressure, immediate sudden decrease of intraocular pressure so that this emboli can actually dislodge and we are trying to reopen the artery. What are the options? IV methylprednisolone. Now, this is given when there is an inflammatory cause of CRAO, right? Like in giant cell arteritis. Ocular massage with anterior chamber paracentesis. Looks like this should be one of the immediate measures. Intravitreal anti-VEGF has no role here. We go for IV acetazolamide. You remember, for sudden decrease of intraocular pressure. We go for carbogen inhalations. And therefore, of course, panretinal photocoagulation also does not have any role here. So, what is the answer? Ocular massage with anterior chamber paracentesis. Right? What is the aim? Sudden decrease of intraocular pressure so that the emboli can dislodge. So, what are the other measures? IV acetazolamide and of course carbogen inhalation to cause vasodilation. Okay, so revise your central retinal artery occlusion here. Another important thing, cherry red spot, we will not forget to learn the differential diagnosis of cherry red spot. Please do this. What had we learned earlier? I always give you under 3 broad headings: central retinal artery occlusion. It could be Berlin's edema, which is commotio retini, which happens in blunt trauma. And the third we go for is storage disorders, isn't it? So, all the depositions or storage disorders like Tay-Sachs disease, Niemann-Pick, Gaucher's, GM1 gangliosidosis, which type 2 and so on. So, please revise your different causes of cherry red spot. Okay, we come to this next question. So coming to this next question, we have to match the following. We are talking about chiasmal lesions. Very quickly, first of all, what have we learned for chiasmal lesion? Let me revise it with you. First of all, it can be exactly a central lesion, that is at the decussation of the two nasal fibers. So if the lesion is somewhere here at the decussation of two nasal fibers, naturally if the two nasal fibers are gone, it is bitemporal hemianopia. And if this lesion is instead at the junction of chiasma and your optic nerve, this is what is called junctional scotoma of trachea. Revise your videos which we have learnt in the class what are the different lesions of the chiasma. So when you say junctional scotoma of trachea, it is mainly anterior chiasmal lesions. And when you go posteriorly, posteriormost fibers, if they are involved, these are macular fibers and can lead to macular, again heteronymous hemianopia. We have learned this. So I think if you draw the field effect here, this lesion is going to lead to a field effect something like this. Do you all agree? If this is your left field and right field, both sides you are going to get bitemporal hemianopia, right? And if we are talking about your second option is anterior chiasmal lesion, which you call junctional scotoma of trachea. So if there is an anterior chiasmal lesion, now in this what is happening? It is the, we have learnt now, it is the anterior Wilbrand's knee which is affected, which are superonasal fibers, right? Inferonasal fibers, and therefore you get a superotemporal field effect in the, due to the chiasmal fibers which are gone, right, in the chiasma. So what is the field effect? We have learnt the side where the nerve is gone, you get central scotoma, and the opposite side what you get is, so what we get here is central scotomas with superotemporal quadrantopias, isn't it? With superotemporal quadrantopias. Right. Why? Because again we are revising, it is the anterior Wilbrand's knee which are the inferonasal fibers. Everybody remembers ye kaun se fibers hote hain? These are the fibers which detour towards the opposite side and then go cross to the opposite side. First they detour towards one side and then cross. That is why you must have seen the slides also. So this is your anterior chiasmal lesion. So we come back to this question. If you have got this background, we will come back to the question to learn further. So match the following chiasmal syndromes with their characteristic visual field effects. If there is an anterior chiasmal lesion, just now we learnt it will be central scotoma and superotemporal quadrantopia. So what should be the answer here? I think it should be number 2, that is junctional scotoma, which is central scotoma in one eye with temporal hemianopia in there. It should not be temporal hemianopia, it has to be superotemporal quadrantopia. So there is some problem with this question. Okay, I am not totally agreeing with it, but still I am discussing this with you. Superotemporal quadrantopia. Let's say this one. Then middle chiasmal is central chiasmal. We call them central chiasmal. That's what you have learned. So central chiasmal means both side temporal fibers are gone. So it's a bitemporal hemianopia, right? Then we talk about posterior. So what we have learnt is macular heteronymous hemianopia. To make our life simple, let us stick to that. Yes, but by exclusion we know that this is actually also causing paracentral bitemporal field effects. You may not learn it, you may learn it. Coming to lateral chiasmal, so I would like you to stick to the whatever portion I have covered in the class videos. So lateral chiasmal means if the lateral chiasmal is gone, naturally there has to be binasal hemianopia. So here it will be binasal hemianopia. Now this is mainly happening due to pressure on the third ventricle, right? So normally, frequently what they ask you most commonly is 1 and 2, that is your anterior junction syndrome and your central chiasmal lesions. Chalo, ek baar aur batao, how do you draw the posterior chiasmal wala? So this is anterior, this one is central, and if we revise for the posterior chiasmal lesions, kya padha tha? Hum log ne padha tha that there are macular fibers involved. So think yourself, if only macula is involved and it is mainly heteronymous, so you will get one this side, one this side. This is what is called macular heteronymous hemianopia. Okay. So just revise it like this. So this was your chiasmal lesion. I hope now it's clear to you all. Right. I think we have covered this. So here the answer would be A, isn't it? The answer is A. Did we mark the answer here? Yeah, we had. Okay. We come to the next question now. So the next question is this one. 65-year-old African American male with family history of glaucoma is presenting with intraocular pressures of 28 in the right eye, 26 in the left eye. Okay, so pressures are high in both eyes. We know a normal pressure is of intraocular pressure is 10 to 21. Visual field is showing arcuate scotoma, means it's a late defect. Late defect means there has to be significant damage. And disc appearance. If you look at the disc appearance, actually the bending is out here. So up to this much is cupping. Okay, don't be confused. Up to this much has to be cupping because here the bend is here. So now we are asking you, what is the most appropriate initial medical management? What are we giving in the initial medical management? Whatever type of glaucoma actually I have taught you, both in open angle and angle occlusion. But here in an open angle, we are going to give what? Latanoprost. We start with prostaglandin analogs. Always start with prostaglandin analogs. Very famous name is 9 p.m. eye drops, where you are putting it once daily at 9 p.m. Right? So here we know that timolol is what? A beta blocker. Right? Whereas answer would be latanoprost. This is PG analog. Right? Brimonidine again an alpha agonist, and dorzolamide we all know is CA inhibitor. Right? A topical carbonic anhydrase inhibitor. So all of you please revise your anti-glaucoma drugs. It is very, very important topic. Okay? Most common side effect of this latanoprost, what have you learnt? Most common side effect you have learnt is, it can lead to, not most common, don't learn anything like most common, but one of the side effects for latanoprost you have learnt is heterochromia iris, because the eye in which you are instilling, it causes darker iris. There is hyperpigmentation there, more melanin expressions, right? So there will be difference of iris color between the two eyes. And any difference of iris color between the two eyes is leading to heterochromia iridis. So we have learned this. This has been your exam question that can lead to heterochromia iridis. Chalo. So this was simple. We come to the next question. Next question says, a 52-year-old myopic male presenting with sudden onset of floaters, there is photopsia, flash of light, peripheral visual field defect in his right eye, indirect ophthalmoscopy is showing a grey elevated area, that means there is retinal detachment, and the retinal break is located in the upper temporal quadrant. So it is a case of rhegmatogenous retinal detachment showing floaters, photopsia, and the break is on the upper temporal quadrant. What is the most appropriate management? Of course, the management was always aimed in closure of the retinal break. So how to do that? These are the options with you. Scleral buckle to seal the retinal break and provide external tamponade. Yes. Pars plana vitrectomy with internal drainage of the subretinal fluid and endolaser photocoagulation. Now, and third is observation and serial monitoring as the detachment is peripheral. So we know that we don't have to monitor anything. Once there is a retinal break, it should be closed and immediately done, isn't it? So 3 can never be an option. If it was my choice, answer should have been only 1, right? But yes, if there is any hemorrhage, then only I can go for pars plana vitrectomy also, and if there is a, of course, drainage of the subretinal fluid, so that we all know about the DAYS procedure, drainage, air injection, and then C for cryo and E for encirclement. That can be done in a rhegmatogenous eye. Therefore, both 1 and 2 should be included, right? Can be included. So we answer 1 and 2, that is your A. Okay? Okay? Yeah. So this is another. So here instead of cryo, we are doing endolaser photocoagulation, whatever it is. Main thing is drainage and then closure of the break and then buckling. That is important. So answer we can include is 1 and 2. One more question I want to discuss. I hope you remember this, and that is your Schaffer's sign. So revise here. Rhegmatogenous RD can be presenting with Schaffer's sign. Kya tha Schaffer's sign? We also call it tobacco dust. And Schaffer's sign or tobacco dust is nothing but pigment dispersion which is seen in the vitreous. Pigment dispersion, lot of pigments in the vitreous like a tobacco dust. This is a sure shot sign that there is a retinal break. Okay, it is a sure shot sign that there is a retinal break. So 1 extra point here. Okay, yeah, we learned 1 extra point in latanoprost wala question, that HI, that is heterochromia iridis, is one of the complications of your prostaglandin analogs, isn't it? And what your first question? That was again extra points about cherry red spot and what are the differential diagnosis and how you manage a central retinal artery occlusion. And yes, what are the different lesions when you talk about chiasmal lesions? That was a quick recap. We come to our next question. A 28-year-old is presenting with sudden onset of pain, redness. So, he's a 28-year-old man with sudden onset of pain, redness and photophobia and watering in the right eye for past 2 days. On examination, circumcorneal congestion, keratic precipitates, cells and flare. We are talking about anterior uveitis. The patient also has slightly irregular pupils. So, that means it may be repeated attack because it has to be a little more older history so that synechia are formed and posterior synechia will be formed if it is so. Anyway, which of the following is the most appropriate initial management? What is the choice of treatment of anterior uveitis? क्या पढ़ा था हमने? It has to be topical steroids and topical cycloplegics. Of course, we are giving it almost simultaneously. So, we should ideally answer both A and B. Right? I think everybody must have answered this. It's a simple question. Right. We come to the next one. 60-year-old patient with poorly controlled diabetes. So, diabetes is poorly controlled here. है ना? Okay, keep that in mind. With new onset of floaters and blurred vision. Poor controlled diabetes. Do you all remember I taught you about retinitis proliferans can lead to 3 blinding complications, vitreous hemorrhage, tractional retinal detachment and neovascular glaucoma. So, when there is a poorly controlled diabetes, we can talk about the vitreous hemorrhage because that will be the one cause where there will be new onset floaters and blurred vision, isn't it? So, sudden onset of floaters with blurred vision. It has to be vitreous hemorrhage. Fundoscopy is revealing an extensive retinal neovascularization and vitreous hemorrhage. So, everybody don't forget that diagram which we draw. These are the different layers of the retina and this is your vitreous and how a neovascularization, this is going to the vitreous, bleed here causing vitreous hemorrhage. It can cause hypoxia of the iris leading to rubiosis, iritis and neovascular glaucoma, and how this neovascularization can pull and lead to tractional retinal detachment. You remember this? Yeah. So, here what should you answer? The most appropriate treatment to reduce the risk of severe vision loss in this patient. So, now severe vision loss can happen due to what are the conditions we have just discussed. What is the most appropriate? Should we go for intravitreal anti-VEGF injections? Such advanced case, is there any role? It will be only our next step because it's already a neovascularization is already there. This patient is a proliferative diabetic retinopathy. Okay. So, in a proliferative, we have learned what is our first step. We go for PRP. There is already vitreous hemorrhage. We have to do pars plana vitrectomy. So, our answer will be 2 and 3. So, we should answer B. That is 2 and 3. Isn't it? Correct? All of you agreed? Intravitreal becomes the last option. So, first of all, it is asking you that what is the most appropriate treatment to reduce the risk of severe vision loss. Initially, it should be your pars plana vitrectomy with PRP. It is, so intravitreal injections come as after doing a 1 or 2 sessions of PRP. If it is not actually responding, we can shift to intravitreal as well. We can add intravitreal injections to this, right? So, most appropriate treatment to reduce the risk of severe. So, actually why I am saying it again and again, because if you see here 1, 2 and 3 both are correct, but initial should be first 2 and 3. So, I am preferring to answer 2 and 3, right? Okay. So, that was all. Thank you so much. Stay blessed and keep smiling.
So this is the Obs and Gynae INI-CET Champions Test 2 discussion of the video solution of the questions asked in the Champions exam. So the first question, a 32-year-old G2P1 and she is at 34 weeks of gestation. She presents with blood pressure of 170 by 110. So that is crossing the threshold of 160 by 110. So yes, this in itself means it is severe, right? And 3+ proteinuria is also there, and look at the other findings, right? Thrombocytopenia is also there, enzymes are also elevated, and on top of that visual disturbances are also there. right? So if you look at the diagnosis, we're looking at a case of severe preeclampsia with signs and symptoms of impending eclampsia as well, meaning that convulsion could happen, and eclampsia could happen at any given point in time. Now, her previous pregnancy was uncomplicated. This is an extra information. What is the most appropriate immediate management for this patient, right? So we want to stabilize the woman, and because signs and symptoms of impending eclampsia is there, right, we need to give prophylactic magnesium sulfate also on priority to prevent convulsions, and we need to plan the delivery as well. Right? Now, if you look at the options, delivery within 24 hours, that makes no sense, right? After corticosteroid administration. I mean, we don't need to wait for steroid administrations. It's 34 weeks, right? And that is completed. So this is wrong. We have to act fast, right? So it has to be immediate delivery. Magnesium sulfate loading dose, 4 gram IV over 20 minutes, then 2 gram per hour. So the dosage of magnesium sulfate they have given in the question is according to the Zuspan regime, right? And that seems fine. And what did I tell you? Magnesium sulfate is priority. So this seems like the correct answer. If you look at the next two options, labetalol. Yes, you do need to give IV labetalol as well to control the hypertension, right? To bring down the blood pressure fast, because you see here that magnesium sulfate is not having any antihypertensive effect. So you will have to give labetalol, right? But magnesium sulfate is still going to be the first priority, right? On top of that, in this question, if you read that we do give 20 milligram IV bolus, and we tend to repeat it every 10 to 15 minutes till the blood pressure comes down to low levels, but maximum is 220 milligrams. So this option is also incorrect, and there's no question of expectant management until 37 weeks. In mild preeclampsia, as long as it remains mild preeclampsia, mother and baby are doing well, or as long as the blood pressure remains controlled, then we can go till 37 weeks. In mild preeclampsia cases, not in severe preeclampsia cases. So D is also out. So your answer is option number B. That is your correct answer. Magnesium sulfate, right? That is priority. And I explained to you this is for prophylactic magnesium sulfate for prevention of convulsions. We have this neuroprotective role of magnesium sulfate. Keep that in mind. And also remember the conditions where you are going to deliver a patient of preeclampsia, irrespective of period of gestation, right? So eclampsia, you all know we have to deliver, obviously. Other than that, if there is signs and symptoms of impending eclampsia, okay. Also remember if there is placental abruption. Also remember if there is HELP syndrome, okay. Right? And also remember that if there is fetal distress, and we know it to be a viable fetus, okay, that is the situation where you deliver irrespective of period of gestation. Now the next question, a 35-year-old primate at 12 weeks of gestation in the first trimester, she has increased nuchal translucency of 4.2 mm. We know that more than 3 mm is abnormal. So raised NT is there, right? Absent nasal bone is also a soft marker for Down syndrome, and cystic hygroma on ultrasound. Now, cystic hygroma on ultrasound, as the image shows you here, right? Cystic hygroma is a venolymphatic malformation. Fluid-filled sacs are there behind the nape of the neck, okay, arising from that location, and they can be huge and large also. So, in the posterior neck area, fluid-filled sacs are there, as we can see in this image. Now, cystic hygroma is a major anomaly. It's a major marker. It's not a minor marker anymore for aneuploidy, for the risk of aneuploidy. And this much information is enough for attempting the question, right? Because again, when you read the complete question, you'll think that maybe, these values are given. This is just extra information. You can answer with this much information also. Like if you look at it, serum HCG is given of 3.2 mom. And PAP is given of 0.3 mom, right? Multiples of median, right? So we know that in trisomy 21, Recall high, I told you, right? HCG is high and inhibin is high, rest all the markers are low. So HCG is high, right? The cutoff is 2.0 multiples of median. And PAP is low here. The cutoff is 0.5 multiples of median to call as low. Now don't get scared. You don't need to really mug up these values. When a question like this comes, you have to look at the keywords. The keyword here is cystic hygroma actually. A very important marker for the increased risk of aneuploidy in the fetus. So you do need a karyotypic analysis. Right? So yes, you do need a karyotypic analysis, and right now she is 12 weeks of gestation. So we can do it by chorionic villus sampling, right? So invasive fetal testing is done. Invasive fetal testing is done. Karyotyping will be done on the sample that we take the trophoblast sample, and karyotyping will be done to confirm aneuploidy, if there is underlying aneuploidy or not, right? And if you just dig a little bit deeper into this question, the first trimester combined screen result is also positive in this question, right? So this raised NT and raised HCG, high HCG values, low PAPA values, they are also making the combined first trimester combined screening test result positive. And chorionic villus sampling recall can be done between 10 to 13 weeks of gestation. So that is what we are going to offer, right? Amniocentesis at 15 to 17 weeks. I mean, if we had happened to see the woman in the second trimester, then that is something that we would have offered. Right now, we have the opportunity of going for CVS. So this is out, right? Now, detailed fetal echo. Well, detailed fetal echo will also be done in such pregnancies, provided, let's say, we've ruled out aneuploidy, invasive fetal testing has been done, or let's say the patient does not want invasive fetal testing, does not want to take the risk of invasive fetal testing, then also in evaluation, fetal echo will also come eventually. But fetal echo is done actually at 22 to 24 weeks of gestation. That will also be done. And, detailed targeted sonography at 18 to 20 weeks, that will also be done. But for now, the best answer is CVS. And there is no repeat screening. Once a screen test is positive, there is no repeat or double screening on top of that. Once a screen is positive, then you go for invasive fetal testing. So this is also not your answer. Now, some extra bits that you need to remember is when they talk about cystic hygroma, and why do I say that is such a major marker? Because up to 70% of these fetuses are associated with underlying aneuploidy. Right? And when cystic hygroma has been diagnosed in the first trimester ultrasound, then the most commonly identified aneuploidy is trisomy 21, then monosomy X, and then trisomy 18. So keep these extra bit pointers in mind. And also, let's say even in the absence of aneuploidy, because 70% is the association with aneuploidy, but even in the absence of aneuploidy, there is also increased risk of other structural abnormalities, particularly cardiac defects. And which cardiac defects? Especially, that's very unique, especially hypoplastic left heart and coarctation of aorta. Right? So that is why I told you that, and a full workup will be needed in such pregnancies. But yes, priority should be given to invasive fetal testing and confirming if there is an underlying aneuploidy or not. Right? And fetal echo will also become a part of the workup. Let's say she does not wish for an invasive fetal testing, or let's say that, the aneuploidy has been ruled out and she's continuing the pregnancy, then we need to think of the increased risk of cardiac defects also. Right? Keep that in mind. Now the next question. A 28-year-old gravida 2 para 1, and she is at 32 weeks of gestation. She is having monochorionic diamniotic twins, and there is fetal weight discordance. Twin A is weighing 1800 gram, that's somewhere in the range of 50th percentile, that information is already given, and twin B is weighing 1200 gram, 10th percentile, so that information is already given. Now, what can you make of this? 10th percentile. That's low, right? Estimated fetal weight less than 10th centile. We're thinking about fetal growth restriction. But in which twin? One twin, twin B, right? Amniotic fluid volumes are within normal limits. So weight discordance is also there in twin-to-twin transfusion syndrome. But what is very important in twin-to-twin transfusion syndrome, what is the stage 1? Twin oligopoly sequence, right? In one twin oligohydramnios, in the other twin polyhydramnios. So here the amniotic fluid volumes are within normal limits for both the twins. So that is a crucial information. What is the most likely diagnosis and what is the appropriate management? So twin transfusion syndrome is not the most likely diagnosis for now, right? Twin anemia polycythemia sequence. No, twin anemia polycythemia sequence, one twin is anemic, the other is polycythemic, right? Now to diagnose this, right, there will not be weight discordance in such twins. Only one twin anemic, the other twin polycythemic, and middle cerebral artery Doppler to detect fetal anemia in one twin and polycythemia in the other twin. So Doppler flow studies of middle cerebral artery are used to make this diagnosis, and for now there have been given no information about any congenital malformation in any of the twins, right? However, a detailed obviously workup will be needed. So for now, by simple elimination and simple logic, that one twin is weighing less than 10th centile, this is selective intrauterine fetal growth restriction. And now what do you want to do? You want to intensify the monitoring, right? So weekly monitoring will be needed, right? So weekly monitoring will be needed, right? So please remember here, when we are talking about selective fetal growth restriction, okay, see, both the twins, both the babies could also be growth restricted. Let's say just this, these are both the babies, they are normal, weight discordance is not there. Let's say both of them are growth restricted. Let's say one of them is growth restricted, right? So here both are growth restricted, both are having fetal growth restriction. But since both are having growth restriction, weight discordance is not there. There is no discordancy in weight. Okay, here one is growth restricted and discordancy is also there. Discordancy is also there. Okay, so when we have selective fetal growth restriction, we can or cannot have, we may or may not have discordancy. But discordancy, if there is, we need to consider the possibility of selective growth restriction. Okay, so selective fetal growth restriction plus discordancy often coexist, and discordancy is defined as more than 20%. In this particular question, if you just dig a little bit deeper, larger twin 1800, smaller twin 1500, and then divided by weight of larger twin multiplied by 100. This is somewhere, 16.6, I don't know, something like that. It's not really exactly 20%. So it's just there. Or sometimes, we define this selective fetal growth restriction with a abdominal circumference difference more than 20 mm also. This is also how we define selective fetal growth restriction, right? So even though if you were to dig deeper, however, in solving this MCQ, you did not need to dig deeper, right? So you have to understand here how INI-CET sometimes can trick you with, long questions with extra information that may not even be very relevant in solving the MCQ per se, right? So in this question or in this scenario, there is definitely a concern for selective fetal growth restriction. Okay, and once diagnosed, once selective fetal growth restriction is diagnosed, we need weekly testing. What will we do? We'll go for fetal well-being testing, amniotic fluid volume assessments will be done, okay, and umbilical artery Doppler will be done, okay, so that timely delivery can be attempted. And one bit of extra information, when we are doing this umbilical artery Doppler assessment and we are focusing on the smaller twin, there are 3 types of selective fetal growth restriction, type 1, type 2 and type 3 based on the umbilical artery Doppler findings. So, type 1 is when there is positive end diastolic flow, positive end diastolic flow. Diastolic flow is maintained in the smaller twin. Type 2 is persistently end diastolic flow in the Doppler of the smaller twin, and type 3 is intermittently absent end diastolic flow and reversed end diastolic flow. And very surprisingly, type 3, because there is large artery to artery shunts in the placentas in these monochorionic diamniotic twins, there is lower risk of deterioration, than type 2. So, this is something interesting and unique, right? And this is about selective fetal growth restriction. Keep that in mind as well. And also remember that we are going to go for this extensive monitoring, and we don't want to compromise the healthy twin also. So, if needed, early delivery can be planned, but for now monitoring will be needed, and that is why that is the answer to your question. Next question. A 32-year-old nulliparous presents with 18-month history of infertility. She reports irregular menstrual cycles, BMI of 35, obese. Lab results show LH12, FSH5, the ratio is disturbed, right, more than 2:1. And testosterone is 85 nanogram per deciliter, it is elevated. So, yes, 2 out of 3, menstrual cycle abnormalities, excess androgens, diagnosis, PCOS. And yes, ultrasound demonstrates enlarged ovaries and multiple small peripheral cysts. That's also going in favor of PCOS. Now, what is the most appropriate first-line treatment for this patient's infertility, right? So, if she's dealing with infertility and she needs treatment for that, right, and she's having anovulatory cycles, isn't it? That is why her cycles are irregular in the first place, right? So, she will need ovulation induction now, right? And the drug of choice for ovulation induction in women with PCOS, first line, drug of choice, letrozole. So, that is your answer, right? So, I keep telling that letrozole and clomiphene citrate, both are first line drugs, but if you have to pick one, then it is letrozole, and the option you don't have to choose between clomiphene citrate and letrozole anyways, right? Now, option number B, metformin twice daily with lifestyle modification. Well, lifestyle modification will definitely be done and it will be recommended, right? And it will take some time for it to set in, right? And she can only spontaneously conceive if her cycles become ovulatory. Now, one of the signs of cycles become ovulatory will be that her metabolic status will improve and her cycles will become regular. Then only she can be expected to spontaneously conceive, right? But right now her cycles are irregular. She's been dealing with infertility and trying for 18 months now. So, now it needs treatment with ovulation induction. So, I will not pick this as the most appropriate first line management of infertility all by itself. And metformin can be given as an insulin sensitizer, but again, it is not going to be the most appropriate first line management for infertility. So, for infertility, metformin alone for infertility or metformin alone for inducing ovulation, no role. Okay, and gonadotropin therapy with monitoring. See, gonadotropins are second line ovulation induction drugs in PCOS patients. right? And laparoscopic ovarian drilling is often considered as a last resort, okay? Because laparoscopic ovarian drilling, what happens is that it's an invasive procedure, and with laparoscopic ovarian drilling, the ovarian stroma that is contributing to excess androgens, that is destroyed, right? So that can be attempted as a last resort, but these days with IVF, which is being practiced, the utility of laparoscopic ovarian drilling has decreased, right? So not many people are offering this, but this is one of the potential treatments. But first we will try ovulation induction with letrozole or clomiphene citrate, and then we can move on to gonadotropins for a couple of cycles, and then we can think about what to do next. So for now, most appropriate first line for this patient's infertility, letrozole. Now the next question. Rh negative mother delivers Rh positive baby. That's the scenario given to you. To prevent sensitization, so that is the only information, okay? Rh negative mother delivers Rh positive baby. To prevent sensitization, meaning that mother is not already sensitized. Mother is not already sensitized, meaning she must be ICT negative also. Which of the following is the most appropriate management? So what do we do for prevention of sensitization? Routine antenatal anti-D prophylaxis is one thing that we do, right? Where we give at 28 weeks, full dose, 300 micrograms, right? IM anti-D is given. One thing is that. And after delivery, what do? We give it again, provided that the baby blood group is positive. Isn't it? So, administer anti-D 300 microgram within 72 hours of delivery. That is the most appropriate management. Give anti-D only if the baby shows signs of hemolysis. See, if the baby is showing signs of hemolysis, right, then we will also check DCT positive, direct Coombs test positive, right. Direct Coombs test is testing what? It is testing the Rh antibodies that are there attached to the fetal, now not fetal, basically newborn. We are going to check this in the newborn RBCs. Okay, so direct Coombs test sample is taken in the newborn, and we can detect these Rh antibodies. That would mean that risk of hemolysis is there, signs of hemolysis is there. That means mother had already formed antibodies, and those antibodies had already been transferred. So mother is already sensitized. If mother is already sensitized, there is no prevention of sensitization. So we don't give. Okay, and 50 microgram regardless of gestational age, that is incorrect. 50 microgram is a dose that is given if she is less than 12 weeks, and we are giving for abortion cases, right? So this is not there. And no intervention needed, that is also not correct. That option is entirely wrong. So for this question, your answer is option number A, straightforward. Now the next question. A 34-week pregnant woman undergoes antepartum fetal surveillance. Why? Because she is having decreased fetal movement. So that's the complaint. Ultrasound shows normal amniotic fluid volume. First point. Second point, normal fetal breathing. Normal amniotic fluid volume, normal fetal breathing. So I'm ticking 2 points here. Absent fetal movements, absent fetal tone, non-stress test negative. So 3 points. In 3 points, she is not getting any score. 0. What are we talking about? We're talking about biophysical profile, Manning score. Either a score of 0 is given, either a full score of 2 is given. It is all or none. So 0 here, 0 here, 0 here. And only 2 things are normal there. Normal amniotic fluid volume and fetal breathing is also there. So 2 plus 2, the score is 4. We know that a score of 8 or 10, that is normal. Score of 6, equivocal. They're not asking about equivocal. They will never ask about equivocal. 4 and 2 and 0, they are bad scores. Score of 4, think, she's already 34 weeks. There's no point in expectantly managing this woman. She's complaining of decreased fetal movements also, right? So repeat fetal surveillance is done when the scores are equivocal and we are unsure whether we should deliver or not. Here, I am very sure that I need to deliver. So expectantly, no. right? Now, immediate delivery without corticosteroids or administer corticosteroids and deliver. So, she is just there at the threshold of 34 weeks. That is why among the two options, I will choose administer corticosteroids and deliver as the better choice answer between the two. So, see this chart from Williams Obstetrics. See, look at this chart. Let's just go through this chart. Broadly, you need to remember, if the score is 10, right, or if the score is 8 by 10 with normal AF, amniotic fluid volume, or 8 by 8 and, NST is not done. Look at this. Normal. There is no indication of delivery. Just repeat testing weekly. Score of 6 is equivocal, and if with all these scores, if she's already term more than 37 weeks, then there is no point in waiting, she's already more than 37 weeks, we deliver. But if less than 37, we can repeat the test in 24 hours with equivocal scores. So, broadly remember this, right? So, with equivocal scores broadly, if more than 37, it is better to deliver, why wait? And if she's less than 37, we can give her some time, repeat in 24 hours. And also remember here, I'm only highlighting the key important things to remember because this is a very big chart and nobody remembers this, and so it's okay, you don't need to mark this up completely. Score of 4 is bad, probable fetal asphyxia. If she's more than 32 weeks, deliver. If she's less than 32, individualize the management based on maternal and fetal conditions, right? So, individualization of management situations will not be given to undergraduate students. Remember, they will always give you a situation where you will realize that it is safer to deliver. She'll be more than 32 weeks and, you will, if she is less than 34, then you will have to give steroids also. In this particular question, she was just there at 34. There was an option of giving steroids, so I chose that as the best choice answer. And 0 to 2, almost certain fetal asphyxia, deliver. Okay. Now, the next question. A 28-year-old female presents for routine cervical cancer screening. Her last pap smear 3 years ago was normal. Current pap smear shows ascus, atypical squamous cells of undetermined significance with no prior history of abnormal pap results. What is the most appropriate next step? So, nowhere is it given that, she's also undergone an HPV DNA testing. So, see, what did I tell you about the screen, triage and treat strategy? See, if she had LSIL, high SIL, ASC-H, then we go for colposcopy. Abnormal screening test results, we go for colposcopy. Here it is atypical squamous cells of undetermined significance. She's also a young female, right? So, might as well go for HPV triaging, right? And one way we can do that, let's say for example, her current pap smear, I'm assuming it must be a liquid based cytology. Why? Because of the options. See, repeat pap smear in 12 months is an option. It's not like it's not an option. Okay, she can choose to say, okay, no, I will repeat the pap smear. But the point is that generally women with that, stress of having an abnormal result, and the, doctors also, they think that, why sit on an abnormal smear result? Let's just, go for some additional triaging. So, triaging is always preferable, right? So, repeat is an option, but it is not the most appropriate next step. Vaccination, out. This option is entirely incorrect. She is undergoing screening, right? And she has an abnormal result. Vaccination is out of the question right now. And immediate colpo with cervical biopsy, I would say she is young. 28, right? Not immediate colpo. Here, I would like to go for triaging, right? So, HPV co-testing with the current specimen. HPV co-testing with the current specimen is possible if we have done a liquid-based cytology. From the same specimen, we can request now HPV DNA testing also. Okay, if in case it was a conventional cytology, not liquid-based cytology, we would have taken a fresh sample for HPV DNA testing, right? So, remember, I have told you this in the lectures also. Ascus, we go for triage with HPV DNA testing. This we need to do. We can do it with the same specimen, current specimen, if the current specimen was of liquid-based cytology. If the current specimen was of conventional cytology, I would take a fresh sample for HPV DNA testing, right? So, answer is option number D. And if this comes out to be positive, right? If this comes out to be positive, then we can go for a colposcopy. And if this triage comes out to be negative, then we can keep on follow up with cytology, or we can follow up with HPV DNA testing. Okay. Now, next question. Now, you have to match the description to the maneuver name. Attempting such questions, when you have matched the column kind of questions, please remember that be sure of at least one. That many times eliminates the rest, eliminates at least two options. Here, if you follow that strategy, it is eliminating all the rest of the three. That is how you're going to quickly attempt such questions. Hyperflex the maternal thighs onto the abdomen to rotate the pelvis. This is Mac-Roberts. The first one is matching with A. I'm sure about that. I am sure about that. Even if you're not sure about the rest, it's fine. You see? This is your answer. One matching with A, 2 with B, 3 with C, 4 with D. That is, they're given in a matched order also. Sometimes you'll wonder, it is so simple. They're given in a matched order. But then again, you overthink and then you may do it incorrectly. So at least be sure about one option, right? Now let's look at the other options also. Mother on hands and knees, the knee chest position to increase the pelvic dimensions and free the impacted shoulder. This is Gaskin's all four, right? And rotational maneuvers, where we rotate the fetal shoulder, the impacted shoulder. You try to free the impacted shoulder by rotating the posterior shoulder towards the anterior with the finger movements and with the finger movements, corkscrew movements. There are two of these rotational maneuvers. One is Rubin's and one is Wood's corkscrew maneuver. So this is also correctly matched. And push the fetal head back into the uterus and then deliver by cesarean section. This is the last resort, Zavanelli maneuver. Okay. Now the next question. A 35-year-old woman who smokes 1 pack per day. Okay. So age is 35. Along with that, she's a smoker. BMI of 32. She's overweight, nearing to obesity. Yes, of course. And blood pressure is 140/90, let's say hypertensive. And she requests a highly effective reversible contraception. What is the most appropriate recommendation? So estrogen, I will not prefer to give. So combined oral contraceptive pills, the contraceptive patches, they are also combined. I will not give. I can give progesterone only contraceptives, right? Now there are two. Mirena is also progesterone only. Depomedroxyprogesterone acetate is also progesterone only. Now you have to choose between the two. What did I tell you? In hypertensive women particularly, in obese women particularly, Mirena is a wonderful way to give contraception and to give drug benefit. Why? Because it releases the progesterone locally and it has effect on the endometrium, causes endometrial thinning, right? So systemic side effects are very, very less, okay? So, particularly obese women also for that matter, because progesterone causes bloating and, water retention and weight gain, right? So, if you look at the entire profile, I'm more in favor of giving Mirena rather than depomedroxyprogesterone acetate. And the reason I have told you, right? Less of systemic exposure to the drug, right? Particularly very preferable in obese and hypertensive women. Right? If she doesn't want to opt for Mirena, yes, other progesterone only forms like injectables can be given, right? Or for that matter, copper T could also have been used in her. Copper T has no hormone at all. But we are asked to choose from these 4 options. So among these 4 options, the most appropriate recommendation is Mirena IUD. However, copper T would have been a wonderful choice because no hormone exposure would have been there at all. Right? But again, we have to choose from the options that are provided. So from the options that are given, most appropriate is Mirena IUD in this particular case. Okay? 32-year-old woman in active labor, 39 weeks. So that's fine. She's term in active labor. She's 6 centimeter dilated, vertex at 0 station. Persistent late deceleration for 20 minutes despite resuscitation. That is your clue. So resuscitation has already been done, meaning giving IV fluid, stopping oxytocin, observing for a while, positional changes, left lateral position, oxygen by mask, that must have already been done. That is what they're saying. This is despite resuscitation. So I'm assuming that this has already been done. So I have to deliver now because these resuscitative changes, they're not working. And she's 6 centimeter dilated, vertex at 0. She's not fully dilated. Station is also at 0 only. She is not fulfilling the criteria for instrumental vaginal delivery, right? So now I will go for immediate cesarean delivery. That is your best choice answer. No instrumentation because criteria is not met. And amnio infusion, well, the only indication for amnio infusion is persistent variable decelerations. In a case of oligohydroamnios during labor. Okay. For that, we can try amnio infusion. Here, they are talking about late decelerations. They are happening because of fetal hypoxia or uteroplacental insufficiency. And if it's not getting corrected despite resuscitation, it is better to expedite delivery. As simple as that, common sense logic. And amnio infusion for persistent variable deceleration could be attempted in laboring patient with oligohydramnios because variable decelerations are happening because of cord compression. And with oligohydramnios, cord compression is more likely to take place. So that is why amnio infusion can be attempted there. Please, amnio infusion means, just to recall, that saline is introduced inside the uterine cavity. How? Via the cervix, okay? With the drip set, we introduce the saline via the dilated cervix, and with the drip set, we push it in. And that is the amnio infusion we are talking about, okay? So that is something that is not done. A 28-year-old woman develops heavy vaginal bleeding after uncomplicated vaginal delivery. Estimated blood loss is 800 ml. So this is obviously fulfilling the criteria of PPH. This is more than 500 ml blood loss. On physical examination, uterus is enlarged and boggy, atonic. Her vital signs are stable. What is the most appropriate initial step in managing this hemorrhage? So what is the most appropriate initial step? Yes. Simultaneous resuscitation and atonic uterus, uterotonics, and bimanual uterine tamponade, uterine massage, this will be done, right? So obviously just eliminate the options. No immediate hysterectomy. Why? Okay, and preference is given to uterotonics and massaging the uterus. That would be your immediate response. Here they are saying 10 units IM, but I would prefer to give by IV infusion. Okay, remember for PPH, prefer to give by IV infusion. So I will still pick up this as the answer. Don't worry about the units here because the rest of the two options are entirely incorrect. Okay, uterine artery embolization via interventional radiology, not at all. Come on, I mean, this is something that is happening in the labor room. I mean, you will act immediately. So this doesn't make sense, right? And exploration of birth canal for lacerations. That you will do. You will see whether the placenta delivered is complete or not, or maybe some bits of placenta or membranes are still retained inside. You will explore the birth canal for lacerations also. Look at if the bleeding is happening for the episiotomy site or there is any cervical or vaginal laceration that is also bleeding and contributing to PPH. But what about this atonic uterus? This you cannot disregard, right? So for that, you'll have to give uterotonics. So for now, the initial step in managing this condition is massage with oxytocin 10 units IM. That's your answer. Okay. 28-year-old woman at 6 weeks of gestation presents with pelvic pain, vaginal spotting, beta HCG 2000. TVS shows empty uterus and a left adnexal mass of 3 centimeter size. What is the most appropriate management, right? So the diagnosis is ectopic. And there are no signs and symptoms being mentioned of ruptured ectopic, right? There's no mention that she's unstable. There's no mention of hemoperitoneum, right? So she is most likely a diagnosis of unruptured ectopic, okay? And medical management, wherever feasible, can be attempted first and should be attempted first. What is the criteria for medical management? She should be stable. There should be no contraindications to methotrexate. No contraindications have been mentioned in the question. She should be compliant to follow up. HCG should be less than 5,000. Here it is 2,000, right? The size should be less than 4 centimeter. Here it is 3 centimeter. Cardiac activity should preferably be absent. They have not mentioned cardiac activity, so we are assuming that it is absent. Most of the times it is a complex adnexal mass where we don't get any evidence of cardiac activity. So this is considered absent only, right? So we can give single dose methotrexate 50 milligram per meter square IM, right? So single dose therapy is preferable, and that is what we do. Serial beta HCG monitoring is no longer needed because we have diagnosed already based on the clinical profile that this is ectopic pregnancy, right? Serial beta HCG monitoring is done when there is pregnancy of unknown location. Now, laparoscopic salpingostomy or salpingectomy with tube preservation or tube removal is something that will come later, right? So surgical management, if you look at surgical management of unruptured ectopic, that is done, let's say, when there is any contraindication to methotrexate, right? When she is not fulfilling the medical management criteria. Okay, fine. And let's say when there is failed medical management. Okay. Now, since it is unruptured ectopic, patient is obviously stable, we are going to go for preferably laparoscopy. Then the question comes whether salpingostomy or salpingectomy, right? So here, if the other tube is healthy, or let's say the woman's family is complete, then salpingectomy is done. Okay. If there is concern of infertility, she has a history of infertility also, we want to save the tube, the other tube is unhealthy, and we think that we should make the most attempt to save this particular affected tube, then we attempt, this is one of the situations where we attempt salpingostomy. Okay, fine. Now the next question, a 55-year-old postmenopausal woman, 3-month history of progressive abdominal distension, palpable irregular pelvic mass. Lab studies show markedly elevated CA125, CT scan demonstrate a complex ovarian mass, diffuse peritoneal implant, significant ascites. Diagnosis of ovarian cancer is there. Biopsy confirms the diagnosis of high-grade serous cancer. However, biopsy is not always necessary to make the diagnosis, but they have given this information, so I'll go ahead with it. High-grade serous carcinoma. Consider these findings. What is the most appropriate treatment approach for this particular patient? So please remember that surgery is the first line treatment for ovarian cancer, right? Now this is advanced cancer. Obviously, from the, it looks like advanced, isn't it? The CT scan is demonstrating peritoneal implants and, ascites and everything. So, this is advanced cancer. So, for now, it will need primary cytoreductive surgery, that is debulking surgery, followed by adjuvant chemotherapy, right? Followed by adjuvant chemotherapy. Adjuvant chemotherapy will be carboplatin plus paclitaxel combination. All right, fine. And radiation therapy to the pelvis with concurrent chemo and everything is not a primary modality of treatment of ovarian cancer. Palliative chemotherapy without surgical intervention is something that is not the standard of care for these patients also. And neoadjuvant chemotherapy, I remember telling you in the main lectures basically that neoadjuvant chemotherapy, the role of neoadjuvant chemotherapy meaning giving chemo before and then interval cytoreductive surgery, interval debulking surgery later on after the cancer shrinks some bit. So that has a role. Let's say in advanced cancers, yes, where there is low likelihood of a successful debulking surgery. Or she is a surgical high risk candidate and we don't want to give her the risk of surgery, then we can think of neoadjuvant chemotherapy, and then at a later point in time we can reconsider the idea of interval debulking or interval cytoreductive surgery, but this is also not the standard of care. So there are cases where neoadjuvant chemotherapy followed by interval debulking is being done, but for undergraduate students, please remember that when you're talking about ovarian cancer patients, your surgical management is the first line management, right? So clinically, if we say apparently stage 1 and stage 2, it is surgical staging. It is surgical staging, right? Which involves TH plus BSO, right? Infracolic omentectomy also, pelvic and para-aortic lymphadenectomy also. And if it is advanced, seems like stage 3 and 4, debulking surgery and post-operative chemotherapy. Okay, remember this, very, very important point. Also remember, how would you, let's say if you are thinking, how would I know the stage? Broadly remember, na, stage 1 is that it is limited to the ovaries. Stage 2, it has gone into the pelvis, pelvic structures, right? So with the ovaries, there is also, maybe, to the adjacent pelvic structures, uterus and the other fallopian tube also engulfed in the tumor, right? And pelvic peritoneal structures basically, right? And stage 3 is basically the lymph nodes will also be put into stage 3, and stage 3 is that it has gone into the abdomen, intra-abdominal spread. Here in this question, there are peritoneal implants, diffuse peritoneal implants and significant ascites. That is why I am saying it is stage 3. That is why I am saying it is stage 3. Okay, and that is why I am saying primary cytoreductive surgery. Next question. A 22-year-old sexually active female is diagnosed with uncomplicated genital chlamydia by NEET, nucleic acid amplification test. Which of the following regimens are appropriate regimens according to the CDC 2021 guidelines? Now, CDC 2021 guidelines you will find in your Shaw's textbooks also, the latest edition one, and I have done that in the main lectures also. So, doxy, is appropriate. Yes, 100 milligram twice daily for 7 days. Azithro, but 1 gram orally single dose is effective, and levofloxacin orally also once daily 500 milligram for 7 days is also an appropriate regimen. Ceftriaxone is for, not for chlamydia, it is for gonorrhea, and azithromycin 500 is the incorrect dosages. So the correct answer is option number B. 1, 3 and 4 are the correct regimens. Please have a look at this from the main lectures. This is the preferred regimen, the alternative regimen for chlamydia and gonorrhea given to you, and this is the third alternative regimen. And levofloxacin is something that we are generally not using. We are either using doxy or azithromycin, right? Now, please keep in mind that if you have a pregnant woman, and you have to treat chlamydia for that matter, doxycycline and quinolones are going to be contraindicated. Azithro will be your preferred regimen. Okay, and alternatives to azithro would be, in case, erythromycin, amoxicillin. They could be alternatives to azithro. If you have to treat a pregnant woman with gonorrhea, right, then cephalosporins are safe. Azithromycin is also safe. So, ceftriaxone we can give in pregnant woman also, and for treatment of chlamydia, azithro can be given. So, cephalosporins are safe. Azithromycin is also safe. So, use that logic. Okay, even cefixime is safe if you want to give orally, and for chlamydia, azithromycin is safe, right? Like that. So, keep that in mind. And also remember, in pregnant women, gentamicin is avoided. In pregnant women, genta is avoided. This is something that you will not prefer. Okay, 30-year-old man presents with 18 months of infertility, no significant medical history, semen analysis is done, and the question they are asking you, which of the following semen parameters are considered normal according to WHO 2021 reference values? So, semen volume should be more than 1.4 ml, yes. Sperm concentration more than 16 million per ml, yes. Progressive motility should be more than 30%, yes, progressive motility. Total motility should be more than 42%. Normal morphology should be more than or equal to 4%, yes. And vitality should be more than 54%. Okay. So, best answer is 1, 2, 3, 4, not 5. Okay. So, this is your correct answer. You need to remember WHO 2021 reference values. Also remember extra bits that the most important criteria is, if you have to pick one, morphology, then motility, and then concentration. Okay, morphology actually depicts the capacity of the sperm to fertilize. So morphology is the most important, then motility, then concentration. If you have to pick one, otherwise these three otherwise are important. And what is the criteria for morphology? What is the criteria for morphology? Remember, it is the strict criteria. It is the strict criteria. Okay, and also remember, when we say concentration should be more than or equal to 16 million per ml, please remember, concentration less than 16 million per ml would fall under, what do we call it? Oligospermia, oligospermia. Less than 15 million per ml is severe oligospermia, and azoospermia is complete absence of sperms. Absence of sperms in semen is azoospermia. And also have a look here, please remember that the count, when you say normal count is the sperms in the entire ejaculate volume. So that is the count. So count should be more than 39 million per ejaculate. That is the cutoff. Okay, should at least be more than or equal to 39 million per ejaculate volume. Okay. Now the next question, assertion and region based question. See, in a woman with complex endometrial hyperplasia without atypia, no atypia, whether complex, whether simple, you can give progesterone therapy, right? And she also wishes to preserve her uterus. That is extra information. Progestin therapy is the most appropriate initial management. That is a true statement. Reason, is the reason true? The reason for this is, the reason for this particular statement is that when there is no atypia, the risk of progression to malignancy is less, endometrial malignancy is less, right? Now, reason, the other statement, complex hyperplasia without atypia carries a high risk of progression to endometrial cancer necessitating immediate hysterectomy. This statement in itself is false. Complex hyperplasia without atypia carries a low risk of progression to endometrial cancer. It is complex hyperplasia with atypia. Whenever there is atypical hyperplasia, see, recall, remember, simple, complex, hyperplasia, without atypia, 1%, 3% risk of progression to cancer. Simple, complex hyperplasia with atypia, 8%, 29%, right? So what did I tell you? Remember, without atypia, less than 5% risk of progression to cancer. So progesterone treatment, preferably Mirena in today's times. And whether simple, whether complex, but with atypia, 10 to 30%. That is broadly how I remember. 10 to 30% risk of progression to endometrial cancer. So, standard of care, treatment of choice, a simple hysterectomy. No need to remove the ovaries, a simple hysterectomy. Alright. So, in this question, if you look at it, A is a true statement, R is a false statement. So, once you read the two statements, you would realize that this is very simple. You do not even have to worry about options A or B, which become more complex. But for this, C is the answer.
Hello students, welcome to this discussion of the pediatrics questions that were there in this INI-CET Champions test that you recently attempted. So the first question that we'll discuss, a term newborn is delivered. So there is a term newborn, okay, who is delivered after a prolonged second stage of labor. Okay, so there are chances that this baby might have, some problems at birth. At 60 seconds, the infant has a heart rate of 80 per minute. So whenever during resuscitation of a newborn, if you're finding that the heart rate is less than 100 per minute, there is apnea or gasping, we have to start positive pressure ventilation. So here heart rate is 80 per minute, that means it is less than 100 per minute. So you must start positive pressure ventilation. Clear? So heart rate is 80 per minute, gasping respiration is there, central cyanosis is there is some flexion of extremities. So positive pressure ventilation with 21% oxygen is initiated for 30 seconds. Remember, whenever we initiate positive pressure ventilation in a neonate, in a term neonate, we always start with room air, that is 21% oxygen. And in a preterm neonate, if a blender is available, we can start with 30% oxygen. Okay. But there is no improvement. Now, whenever you're doing, you've started positive pressure ventilation in a neonate and there is no improvement, what are you supposed to do? So we have to do ventilation corrective steps. So let us see what are the ventilation corrective steps. So the ventilation corrective steps you can remember by the mnemonic MR-SOPA. Okay, ventilation corrective steps by the mnemonic MR-SOPA. Right? So M stands for mask readjustment. That means you should ensure that the size of the mask is okay and the seal between the mask and face is appropriate. The seal should be tight. There should be no leakage of air. Okay. So the mask should be tight, seal should be made. So mask readjustment. Reposition the airway. That means the head of the baby should be slightly extended. Suction the mouth and nose if there are a lot of secretions. If you feel, always whenever you do suction, mouth followed by nose. Okay. Open the mouth slightly. You can increase the inflation pressure that you're giving by the bag and mask if you feel that the chest rise is not there and the baby is not improving. And you can consider an alternate airway. That means you can consider doing endotracheal intubation or you may use a laryngeal mask airway. Okay. So coming back to our question, so we have to take ventilation corrective steps for the next, that is the most appropriate step in management. Let us see the options one by one. Increase FiO2 100% and continue PPV? No. So did you see anywhere in the ventilation corrective steps that increase oxygen to 100%? No, that is not there in the ventilation corrective steps. Only if the baby continues to deteriorate, the heart rate becomes less than 60 per minute when you start chest compressions, that is the situation when we use 100% oxygen. So this is not the correct answer. Endotracheal intubation, yes, we can do that, but with surfactant administration, no. Surfactant administration is required in preterm babies with respiratory distress syndrome. And there you can give surfactant by the Ensure method. What is Ensure? Ensure is intubate, give surfactant, extubate. Nowadays you also have, LISA and MIST. So what is LISA? Less invasive surfactant administration, where you do not even need to intubate the baby. Right? Similarly, minimally invasive surfactant therapy, MIST. LISA or MIST are also there for surfactant administration. They can be asked in your INI-CET exam. So that is also not the answer. Chest compressions at 100 beats per minute with continued PPV? No. We will start chest compressions in neonatal resuscitation only if the heart rate of the baby is less than 60 per minute, which is not the case here. So no chest compressions. Check mask seal and increase inflation pressure. Yes, that is the best answer because they are the ventilation corrective steps that we need to take. Right? Okay. So clear on this one? Let us move ahead. A 6-month-old infant presents with, so a 6-month-old infant is there who presents with vomiting, hypotonia and developmental regression. So there is vomiting, hypotonia and developmental regression shortly after the introduction of solid food. Now what is important to note is that these symptoms have begun at the age of 6 months when you start complementary feeding. Before that the baby was asymptomatic essentially. Now, physical examination reveals hepatomegaly. Lab testing shows hypoglycemia and elevated lactate. So, we are probably dealing with a disorder of carbohydrate metabolism as there is hypoglycemia also. And some carbohydrate metabolism disorder which starts at 6 months of age when complementary feeding is introduced. And a positive urine test for reducing substance but negative for glucose. So, the most likely diagnosis based on the given case scenario would be hereditary fructose intolerance. Because the symptoms are appearing at 6 months of age. Typically when you start complementary feeding and you give fruits and other things which contain, so you give sweet items also which contains sucrose which breaks down to glucose and fructose, and if the baby is not able to digest fructose, then comes the problem. So hereditary fructose intolerance is the most probable diagnosis here, and you will give a fructose restricted diet. Not galactosemia, here the baby is not having cataracts. Galactosemia, the babies typically become symptomatic within 1 to 2 weeks of age. 1 to 2 weeks of life, they can have jaundice and they can have cataract and lots of other findings. Glycogen storage disorder, again we are not considering because the baby has remained asymptomatic for the first 6 months of life, right? And the symptoms have come only when complementary feeding was started. Fatty acid oxidation defect also we are not considering for the same reason here. So hereditary fructose intolerance, the enzyme deficient we know is aldolase B, or it is also called fructose 1,6-bisphosphate aldolase. Due to deficiency of this enzyme, the excess of fructose 1-phosphate accumulates in the body, which is toxic to the liver and the kidney and various other systems, CNS and all, right? So the typical age of presentation would be around 6 months or beyond that when the complementary feeding is introduced. And you know what happens? These children learn. Whenever they are taking something sweet, symptoms are happening. So they typically develop an aversion to sweet food in some time. So mother will tell you that the child does not want eating sweet food. There can be jaundice, diarrhea, vomiting, hepatomegaly and failure to thrive. And of course, urine reducing substance would be positive and fructose-free diet would be the treatment of choice. Moving to the next question. A 4-month-old male presents with poor weight gain, tachypnea, and recurrent lower respiratory tract infection since birth. So there is poor weight gain, tachypnea, so that means fast breathing is there and recurrent respiratory infection since birth. On examination, there's hepatomegaly and pan-systolic murmur at left lower sternal border. So we are probably dealing with a acyanotic congenital heart disease and a pan-systolic murmur. Hepatomegaly indicates possibly it is a ventricular septal defect. Echocardiography reveals indeed a large perimembranous VSD with left to right shunt and pulmonary artery pressure of 75% of systemic. So the pulmonary artery pressure has started to rise. But till now, reversal of shunt, that is Eisenmenger syndrome, has not developed. There is no cyanosis. We know VSD is a acyanotic heart disease at rest. What is the most appropriate next step in management? So before going to the options, let us discuss a little bit about the management of VSD. So ventricular septal defect, you have a medical management and you have a surgical management. So medical management and a surgical management. Medical management would be, treatment of heart failure. So treatment of heart failure, you would use typically drugs like diuretics like furosemide or furosemide. And you may or may not use digoxin, you may use Envas or enalapril, So treatment of heart failure, treatment of pneumonia as and when it is happening, so treatment of lower respiratory tract infections and nutritional rehabilitation, nutritional rehabilitation. And surgical management, of course, would be closure of VSD. So usually a Dacron patch is used to close VSD. Dacron patch may be used or some device closure can also be done. So closure of VSD. Now what are the indications of surgical closure? So indications would be heart failure refractory to medical management. Heart failure refractory to medical management would be the main indication. And we would like to close the VSD if the pulmonary artery pressure is rising. If pulmonary hypertension has started to develop. Because once the pulmonary pressure becomes more than the systemic pressure, then what will happen? Eisenmenger syndrome will set in and there will be reversal of blood flow. Then there is no point in doing VSD surgery after that, right? So going through the options, so immediate surgical VSD closure appears to be the best option. Pulmonary artery banding followed by delayed VSD closure. We would not like to delay the VSD closure further because once Eisenmenger syndrome or reversal of shunt develops, then there is no point in doing the surgery. The baby is not going to benefit. Medical management with diuretics and ACE inhibitors alone is not going to help because the pulmonary artery pressure has already risen to 75% of systemic. And balloon occlusion of VSD via cardiac catheterization again might not help. So the best answer is immediate surgical VSD closure. So before moving ahead, let us discuss a little bit about the pathophysiology of Eisenmenger syndrome that we were mentioning. So Eisenmenger syndrome sets in when there is increased pulmonary blood flow. Like in a child with VSD, ventricular septal defect to begin with, there is a left to right shunt and there is excess of pulmonary blood flow. Now this excess pulmonary blood flow initially leads to a hyperkinetic type of pulmonary artery hypertension which is reversible. Now slowly what happens? Pulmonary vascular obstructive changes develop and they are irreversible. So obstructive type of pulmonary artery hypertension develops. Now because there is pulmonary hypertension, what happens? The right ventricle has to exert a lot of force to pump blood out against resistance. So there is development of right ventricular hypertrophy. Pressure in the right ventricle continues to rise. A time will come when the right ventricular pressure is more than the left ventricular pressure, and instead of left to right shunt in a VSD, then it will become right to left shunt. If there is right to left shunt, what will happen? Lesser blood will go to the lungs. So lesser blood will get oxygenated and a child with VSD is going to develop cyanosis and clubbing. So if a child with VSD develops cyanosis and clubbing, that means the child has developed Eisenmenger syndrome, and then there is no point in doing surgery in that child, okay, because then you can only do palliative pulmonary artery banding or some other procedures just for palliation, right? Moving ahead to the next question. So a 6-month-old infant presents with recurrent infections, failure to thrive, and absent thymic shadow on chest x-ray. So the thymus is not visualized on the chest x-ray. The laboratory studies show marked CD4 plus T cell lymphopenia, normal B cell and CD8 T cell counts. So CD4 T cells are mainly affected, thymus is not developed, so mainly T cells are affected. Which of the following statements regarding this condition are correct? So recurrent infections and failure to thrive is there. Probably we are dealing with DiGeorge syndrome. Okay, DiGeorge syndrome. So let us first discuss a little bit about it and then we come back to answer the question. So this DiGeorge syndrome is also known as velocardiofacial syndrome, and it is due to a microdeletion in chromosome 22q11. So in the long arm of chromosome 22, so there is a microdeletion that gives rise to it. In order to find a microdeletion, what are the investigations we can use? We can use a FISH, that is fluorescent in situ hybridization. Okay. So there is failure of development of third and fourth pharyngeal pouches and the structures that arise from them. So that is the basic defect that is happening due to this genetic mutation. So thymic hypoplasia is there. So thymus shadow you cannot see on chest x-ray in these babies, right? So the heart will have a narrow pedicle sort of. And so there will be decreased CD4 plus T cells. Parathyroid hypoplasia, because parathyroid also develops from the third and fourth pharyngeal pouches. So there will be hypocalcemia. Ultimobranchial body is also not formed, and there is defect in heart and blood vessels. So this DiGeorge syndrome, you can also remember the clinical features by Catch-22 mnemonic. So C stands for conotruncal or cardiac abnormalities like truncus arteriosus. Tetralogy of Fallot can also be there. A stands for abnormal facies. So these children typically can have hypertelorism, antimongoloid slant of eyes, abnormal nose can be there, short philtrum and mandibular hypoplasia. So small chin can be there. Thymic hypoplasia and abnormal CD4 T cells development, cleft palate and hypocalcemia. Now because thymus is not developed in these children, it has been seen that these children can benefit from thymic transplantation. So severe form of DiGeorge syndrome, advanced mode of treatment, you can implant cultured allogenic thymic tissue. So this early transplantation is crucial to avoid life-threatening infections. But of course, like any other organ transplant or hematopoietic stem cell transplant, it can be associated with complications. To diagnose DiGeorge syndrome, you can get clues from hypocalcemia. Echo will show you the underlying cardiac disease associated with it. Chest X-ray will show the absent thymic shadows. Decreased CD3 and CD4 T cells will be there. And lymph node, if you were to biopsy, you will find parafollicular areas are depleted. Definitive diagnosis, of course, is by chromosome 22q microdeletion, which can be detected either by MLPA or FISH. FISH we know is fluorescent in situ hybridization. MLPA is multiplex ligation dependent probe amplification. So these are important topics for your INI-CET exam. Coming back to the question. So which of the following statements regarding this is correct is the question. So the condition is caused by defective development of the third and fourth pharyngeal pouches is correct. Thymic aplasia or hypoplasia leads to impaired maturation of T cells is also correct. B cell function is usually severely compromised in this condition. No, B cell is not really affected much. Thymic transplantation is a definitive treatment in complete cases. Yes, that is also correct. 1, 2 and 4 are correct. So our option A is the best answer here, right? 1, 2 and 4 are correct, you can see, right? So moving ahead to our next question. Match the following with their genetic defect. So Beckwith-Widman syndrome, we know Beckwith-Widman syndrome is due to a defect in chromosome 11. So it is due to methylation abnormalities on chromosome 11. Achondroplasia we know is an autosomal dominant disorder, autosomal dominant inheritance due to a mutation in the FGFR3, fibroblast growth factor receptor 3. Okay. Cry-do-chat syndrome we know is due to deletion in the, so 5p minus actually it is. Okay. So it is actually deletion of the short arm of chromosome 5. Okay. And Fragile X syndrome is due to expansion of the CGG repeats. Okay. So our best answer would be where A is with option 2, B is with 3, C is with 4 and D is with 1. That is option C, right? Okay. Now, in a child with Sturge-Weber syndrome and intractable seizures. So, Sturge-Weber syndrome is a condition where it is a neurocutaneous syndrome. Okay. So, let us discuss about Sturge-Weber syndrome a little bit and then we come back to this question. So, we know it is a neurocutaneous syndrome where there will be a facial port wine stain, leptomeningeal or brain angiomas can be there, ocular involvement, mostly glaucomas can be there. Now, because of the leptomeningeal angiomas, you can get tram tract calcifications, okay, on imaging of the brain. So, tram tract calcifications can be there, and these children usually have seizures, okay, they can present with seizures. So, coming back to the question. So, we have this assertion and reason kind of a question which you can expect in the INI-CET exams. So, in a child with Sturge-Weber syndrome and intractable focal seizures, functional hemispherectomy may be considered as a definitive treatment is the assertion. So, assertion is correct because wherever you are having, focal seizures, and if they are intractable, and you can see that one particular area of brain is giving rise to those seizures, then surgical treatment, okay, may be considered. So, this functional hemispherectomy may be considered as a definitive treatment. So, assertion appears to be correct. Now, what is the reason that they have stated? Sturge-Weber syndrome causes glaucoma and visual field defects. That cannot be the reason for doing hemispherectomy, right? Which can contribute to neurological morbidity in affected children, right? So, glaucoma and visual field defects definitely can contribute to neurological morbidity. In addition, if the child is not able to see properly also, then the neurological condition will even worsen. So, both assertion and reason are correct, but assertion is not the correct explanation. So, reasoning is not the correct explanation for the assertion here. So, our best answer is B. That is, both assertion and reason are true, but reason is not the correct explanation of the assertion, right? So, moving ahead, a 2-year-old boy is brought to the clinic for evaluation of chronic cough, recurrent respiratory infections and poor growth. His parents report that he sweats excessively and there's a salty taste on his skin. Okay. His older sibling has a similar history. So, family history is also there, recurrent lung infections and digestive problems. A sweat chloride test was performed which revealed 65 milliequivalent per liter. Okay. Which of the following best describes the inheritance pattern and the gene involved in this condition? So, there is no doubt that we are dealing with a case of cystic fibrosis. We have enough evidence here. So, there is chronic cough, recurrent respiratory infections, failure to thrive, salty taste of the kiss, family history of similar illness is there. You have a sweat chloride which is positive, elevated. So, it is indeed a case of cystic fibrosis. Let us look at the diagnostic criteria and then we come back to answer this question. So, cystic fibrosis, there are some clinical criteria, some lab criteria. So, you need one out of the clinical criteria and one out of the lab criteria for diagnosis. So, clinical criteria would be clinical features compatible with cystic fibrosis. So, compatible clinical features would be like recurrent pneumonias, recurrent loose stools, blood in stools, steatorrhea, failure to thrive and so on. Family history of similar illness in a first degree relative, like here in the sibling, there was a similar illness. Newborn screening test for cystic fibrosis is immunoreactive trypsinogen. Okay, IRT or immunoreactive trypsinogen. So, newborn screening positive in the form of immunoreactive trypsinogen. Okay, that is the screening test for cystic fibrosis. Right? Lab criteria would be sweat chloride more than 60 milliequivalents per liter. Okay, on 2 separate occasions. CFTR gene is the one involved on chromosome 7. So, 2 or more pathogenic mutations in the CFTR gene is required and abnormal nasal membrane potential difference. So, that is the diagnostic criteria of cystic fibrosis. So, here we have sweat chloride also elevated, we have clinical features also compatible, we have family history of similar illness as well. So, we have no doubt that this is a case of cystic fibrosis. Now, which is the gene and the mode of inheritance? We all know it is the CFTR gene and autosomal recessive inheritance is the best answer here. Okay. So, moving ahead, a 2-month-old cyanotic infant presents with failure to thrive and tachypnea. Chest X-ray findings are shown. What do you see on the chest X-ray? So, can you appreciate there is this figure of 8 appearance? Okay. So, if you look closely, there is this figure of 8 appearance that you see. Okay. So, I'll just magnify the X-ray for you. So, you can see there is this shadow here. I'll just highlight it. So, this shadow that is there. Okay. This. Okay. And this. So, there is this figure of 8 appearance or snowman appearance, so as to say. Figure of 8 or snowman appearance. Right. So, this is a case of TAPVC, supracardiac TAPVC, right? So, coming back to the question is saying that, echocardiography reveals venous flow away from the heart. So, remember, in TAPVC or total anomalous pulmonary venous connection, you can get on echocardiogram the venous flow away from the heart, because what happens? The pulmonary veins instead of draining into the left atrium, will drain into the right atrium. So what is the basic defect? Let us come back to this question after discussing that. So what happens in your TAPVC is, so in TAPVC, so this is the right atrium, left atrium, right. So right atrium, left atrium, right ventricle, left ventricle. So normally what happens, the pulmonary veins drain into the left atrium. But in TAPVC, what will happen? Instead of draining in the left atrium, the pulmonary veins will drain into the right atrium. So superior vena cava is also draining into the right atrium, inferior vena cava is also draining into the right atrium, and pulmonary veins are also draining into the right atrium. So they usually, what happens, the pulmonary veins will form a vein which will come and, which usually it will drain in such a way. So the pulmonary veins will drain directly or indirectly into the right atrium. So the pulmonary veins will come, and instead of draining into the left atrium, what will happen? They will go and join the innominate vein and then drain into the right atrium. Or, in infracardiac type, they will go below the diaphragm and join the, inferior vena cava and then drain into the right atrium. So on echocardiogram, you can see that there is some venous flow which is away from the heart. So like this, or, like this. So you can see venous flow away from the heart in TAPVC. That is pathognomonic on echocardiogram. Another important thing is, all the venous blood, the pulmonary artery blood, the pulmonary circulation blood as well as systemic circulation blood is coming and mixing thoroughly in the right atrium in total annulus pulmonary venous connection. Now this mixed blood is going through foramen ovale to the left atrium and to the right ventricle as well, and from left atrium to the left ventricle as well. So all four chambers of heart have got equal oxygen saturation. So two very important points. So venous blood flow away from heart, if you are seeing away from heart on echo, and you're getting that all four chambers have equal oxygen saturation. Okay, and just like a ASD, you also get wide fixed split of the second heart sound. So you get a wide fixed split of second heart sound. So these are some very important salient features of TAPVC from which you get questions. And in this condition, giving prostaglandins is not going to help, right? So let us discuss a little bit further and then we come back to the options. Okay. So in TAPVC, what will happen is, the ECG. So if you do ECG, what will happen? So the right side of the heart will be the dominant because it is receiving all the blood flow. So ECG can show right ventricular hypertrophy with a QR pattern in the V3R lead and V1, and P waves are frequently tall and spiked because the right atrium and right ventricle both are enlarged. Echocardiogram will demonstrate a large right ventricle, and you will see that any vein with Doppler flow away from heart is pathognomonic of total annulus pulmonary venous return. Okay, right? So that is pathognomonic. Now coming back to our question. So this is TAPVC, and what is the most appropriate immediate intervention that you would like to do? Most appropriate immediate intervention that you would like to do. So balloon atrial septostomy or Rashkind procedure is not going to help because here it is not TGA. So in TGA, Rashkind procedure helps because it helps in mixing of the circulation of both sides. But here already the blood is completely mixed, right? So balloon atrial septostomy is not going to help. Emergency surgical repair of TAPVR or TAPVC, yes, it is going to help. PGE1 infusion is not going to help, and pulmonary artery banding, reduced pulmonary blood flow is not going to help. So B is the best answer here, right? Now 4-year-old boy. So a 4-year-old boy presents with a barking kind of a cough, inspiratory stridor. So he presents with a barking kind of a cough, inspiratory stridor and fever for 1 day, right? So inspiratory stridor, fever for 1 day. On examination, there is mild respiratory distress but maintains oxygen saturation. A neck x-ray is shown. So this neck x-ray you can see shows the steeple sign. So this is a case of croup, and this is a case of mild croup because there is mild respiratory distress and oxygen saturation is maintained. So the baby is otherwise fine. Okay. So this is a case of mild croup. Mild croup, the treatment of choice is single dose dexamethasone. You can give it orally, you can give it IM, you can give it IV. So dexamethasone single dose is a treatment of choice. If it was moderate croup, then in addition to dexamethasone, we would have given epinephrine nebulization also. Amoxicillin is not required here. It is not a bacterial infection. We know croup is a viral infection. Humidified oxygen with supportive care only will not be sufficient. You will have to give single dose steroid to see that dramatic improvement. So croup, it has mainly a viral etiology, most common being parainfluenza virus. Okay, most common is parainfluenza virus. Acute epiglottitis is mostly bacterial. Most common in the immunized population now is streptococcus, right? Clinical presentation group is, usually it will be a viral prodrome kind of a picture, and then the child will develop barking cough and stridor, and usually a lot of hypoxia and all is not there. So barking cough and stridor will be there, respiratory distress can be there. Acute epiglottitis, on the other hand, has a very toxic kind of presentation, bacterial infection. So the child is sick looking and toxic, and there can be high grade fever and drooling of saliva. The child is not able to swallow his or her own saliva. Of course, stridor is there, okay, in both of these. X-ray picture. So in group we saw the steeple sign, and in acute epiglottitis we get the thumb sign, okay, thumb sign on lateral X-ray of neck, and on direct laryngoscopy you can see the cherry red epiglottis. Treatment of group, we said single dose dexamethasone. Of course, supportive care is required in both, that is oxygen, humidified oxygen, and if required IV fluids and all. So single dose dexamethasone is a treatment of choice in group, even in the mild cases. In moderate cases you add on nebulized epinephrine. No role of antibiotics as such in croup because it is a viral illness, okay. While in acute epiglottitis, it is a bacterial illness, so you have to give IV third generation cephalosporins like ceftriaxone because it is a bacterial illness. Acute epiglottitis is a bacterial illness, so you must give antibiotics, okay. Next question. An 18-month-old child presents for routine checkup. Parents report a lack of speech development. So there is speech delay. The child says only 5 words, whereas at 18 months a child should be able to say 10 words with meaning. At 2 years a child should be able to say 50 to 100 words with meaning. So there is speech delay. And he does not combine words. That's still so isolated speech delay till now. But in addition, the child has poor eye contact, demonstrates repetitive behavior. Hearing strain is otherwise normal. So what is the most appropriate next step? So wherever you're getting poor eye contact and repetitive behavior in this age group, we think of autism spectrum disorder. So persistent impairment in reciprocal social interaction and presence of restricted repetitive behavior or interest is pathognomonic. So impairment in reciprocal social interaction is shown by poor eye contact here. Poor eye contact says it. And restricted repetitive behavior is also there in the question. So we are dealing possibly with autism spectrum disorder, right? So autism spectrum disorder has some risk factors like closer spacing of pregnancies, extreme prematurity, any family member with learning disability, antenatal exposure to thalidomide or valproate, rubella, excessive screen time, which is common in these days, modern households. Screening tool for this is usually MCHAT, modified checklist of autism for toddlers. And the management would be cognitive behavioral therapy. Comorbidities you have to treat, like hyperactivity is there, then you give atomoxetin or methylphenidate, and more social interaction with the child is required. So in this case, reassurance that speech delay is normal and recheck will not help. Immediate referral for autism spectrum disorder evaluation is required because the earlier you start the cognitive behavioral therapy and all, the better it works. Speech therapy alone and developmental assessment will not help. Audiology evaluation despite a normal hearing screen is again not going to help. Right? So moving ahead, a 14-year-old girl presents with short stature. So there is short stature, there is webbed neck and primary amenorrhea. Short stature, webbed neck, primary amenorrhea, my diagnosis clear, Turner syndrome. Her echocardiogram and renal ultrasound, however, are normal. Bone age corresponds to 12 years, so some delay in bone age is there. FSH and LH are elevated. So in Turner syndrome, what happens? It is hypergonadotrophic hypogonadism. There are streak ovaries and rudimentary uterus. So gonads are not well developed. But there is no problem at the level of FSH and LH. They are rather higher. So FSH and LH is elevated. Estradiol is low because the ovaries are not there, streak ovaries, so they are not producing a lot of estrogens. Her genetic testing reveals a complete absence of the second X chromosome with mosaicism. Mosaicism means presence of more than 2 cell lines. So more than 1 cell line. So multiple cell lines are present. So some may be, having XY also, some may be XO, some may be XX. So we don't know. So mosaicism is there. What is the most appropriate next step in the management to optimize growth and puberty? Now, because the child's bone age is less than the chronological age, you can consider giving growth hormone therapy. And once the child has, attained whatever final height, target height is there, then you can start estrogen replacement so that the changes of puberty can come. Because the estradiol is low, the ovary is not able to produce enough estrogens. That is why the features of puberty, the secondary sexual characteristics do not appear. So growth hormone replacement until final height is achieved, followed by estrogen replacement is the best answer here. Immediately you will not want to give estrogen progesterone therapy because then the bones will get fused. Further increase in height is not going to happen. Testosterone therapy will lead to virilization. and GnRH agonist therapy is also not going to help much. Okay. Moving ahead, a 6-month-old infant presents with eczema, recurrent otitis media, pneumonia. So eczema, recurrent infections, easy bruising. On examination, bruising is there, petechiae is there, bloody diarrhea is there, and there is thrombocytopenia. So thrombocytopenia, eczema, and recurrent infections. My diagnosis is clear. It is Wiskott-Aldrich syndrome, right? So Wiskott-Aldrich syndrome is my diagnosis here. Okay. Right, and Wiskott-Aldrich syndrome we know has got a X-linked recessive inheritance. So laboratory findings reveal platelet is 25,000, platelets are small in size, so microthrombocytopenia. Serum IgM is low, IgG is normal, A and E are elevated. All these are compatible with the diagnosis of Wiskott-Aldrich syndrome. Which of the following statements regarding this condition are true? So the condition shows autosomal recessive inheritance due to ADA gene mutation. No, it is what gene is mutated in Wiskott-Aldrich? So it is the VAS gene, which produces the VAS protein, and it lies on the X chromosome. So the inheritance is X-linked recessive. So that is what is affected, right? So the first statement is wrong. Second, characterized by atopic dermatitis, thrombocytopenic purpura, and normal appearing megakaryocytes is correct. HSCT is the treatment of choice is also correct. It is associated with defective T cell cytoskeletal signaling and impaired immune response is also correct. So 2, 3 and 4 are the correct statements. So our best answer is D here. So Wiskott-Aldrich syndrome has been a favorite topic for INI-CET. In various ways the questions are framed. Moving ahead, a 2-month-old infant born at 32 weeks of gestation, currently weighing 4 kg, presents for routine immunization. The infant is otherwise healthy and has no chronic medical conditions. What is the most appropriate vaccination schedule for this infant? Now, irrespective of whether the baby was premature or not, the immunization should continue as per the chronological age if the baby is otherwise fine. So, at 2 months, we will give, in Indian immunization schedule, we have 6, 10 and 14 weeks immunization. So, if the baby has not received the 6 weeks immunization, we will give the standard 2-month schedule. That means a 6-week schedule based on the chronological age for this baby. We will not delay the schedule based on corrected gestational age. We will not modify the dosage, and no vaccinations until the child reaches 5 kgs is also not correct. Now, what is the national immunization schedule? At birth, we need to give BCG, OPV 0 dose and hepatitis B birth dose. At 6 weeks, we give, what are the vaccines that we give? So, we give OPV first dose, Rota first dose, Penta first dose. Apart from that, fractional IPV first dose and PCV first dose. 10 weeks, again, we will give OPV second dose, Rota second dose, Penta second dose. 14 weeks, OPV 3, Rota 3, Penta 3 and FIPV 2, PCV 2. 9 months, we give MR1, PCV booster and JE1 in endemic areas. And of course, we also add on, FIPV has been added at 9 months very recently in 2023, 2 years back, right? 16 to 24 months, MR2, DPT booster 1 and OPV booster and JE2 in endemic areas. 5 to 6 years, DPT booster 2 and 10 to 16 years, TD. 10 and 16 years, TD is recommended, right? Now, moving ahead, a 12-year-old girl is brought to the clinic by her parents with a 3-month history of persistent morning stiffness lasting for over an hour, symmetrical swelling and pain in the wrist and knees. So there is arthritis, not just arthralgia. So an intermittent low-grade fever. So arthritis in a child lasting for more than 12 weeks. So our diagnosis becomes JIA or juvenile idiopathic arthritis. Laboratory tests, however, reveal a positive ANA. So positive ANA can be seen in a wide variety of rheumatological illnesses, including SLE. But positive ANA alone, of course, will not make your diagnosis of SLE. The whole SLIC criteria you have to fulfill. Negative rheumatoid factor is there. Further ophthalmological examination reveals asymptomatic chronic anterior uveitis. Uveitis is also associated with JIA, we know. Based on this presentation, most likely diagnosis. So how many joints are involved? Her wrists and knees. So if you consider both wrists and both knees, 4. So if 4 or less joints are involved, it is oligoarticular JIA. More than 4 joints are involved, it is polyarticular JIA. So systemic juvenile idiopathic arthritis, no, it is not systemic onset JIA. Polyarticular JIA, no, because 4 joints are only involved, not more than 4 as of now. Enthesitis related arthritis, no tendon involvement is mentioned. Oligoarticular JIA is the best answer, and we know uveitis is also most commonly associated with oligoarticular JIA. So regular ophthalmological screening for uveitis is also required. Okay. A 28-week gestation neonate develops feeding intolerance, increasing abdominal distension, visible bloody stools on day 5 of life. So we are definitely dealing with necrotizing enterocolitis. The most important risk factor for necrotizing enterocolitis is prematurity, which is there in this case. An urgent abdominal X-ray is performed, which reveals pneumatosis intestinalis and portal vein gas. Based on these findings, what is the most appropriate immediate management strategy? So let us see this modified Bell staging of necrotizing enterocolitis, and then we come back to answer this question. So stage 1 is NEC suspect. The clinical features would be very subtle, like temperature disturbances, apnea, lethargy, okay? And usually, abdominal X-ray will be normal here. Stage 1A, you will get occult blood positive in stool. Occult blood positive in stool. And 1B, you will get fresh blood in stool. Fresh blood in stool. Okay. The treatment would be NPO, IV fluids and IV antibiotics. You do this for 48 to 72 hours and then we reassess. Okay. Stage 2. Clinical features. Again, the general features would remain the same. Okay, so the baby will might start to have, apart from that, abdominal distension can be there, and there can be some tenderness can be there. So abdominal distension, tenderness, abdominal wall cellulitis and all can be there. Investigation in 2A, you will find portal vein gas. So in 2A, okay, so in 2A, you find pneumatosis intestinalis, air in the wall of intestine. Okay, pneumatosis intestinalis. And 2B, you find portal vein gas shadows. Portal vein gas. The treatment remains same as stage 1 NPO, IV fluid, IV antibiotics, but now you give it for 7 to 10 days at least. Okay, 7 to 10 days. The given case scenario, the child appears to be in stage 2 NEC. So NPO, IV fluid, IV antibiotics are required. Stage 3, the baby is very, very sick. The baby can be in shock. So there can be life-threatening apneas. Okay, life-threatening apneas can be there, hypoperfusion, shock. Okay, and what will happen on investigation? Stage 3A, you will get features of peritonitis. There will be abdominal guarding and cellulitis, abdomen hugely distended. Okay, guarding. So there will be abdominal cellulitis, abdominal wall cellulitis, and abdomen hugely distended, and guarding can be there, right? And 3A peritonitis. 3B, what happens? Intestine has perforated, so you get pneumoperitoneum or gas under the diaphragm. You can get as an image based question also, pneumoperitoneum or gas under the diaphragm. The treatment would be same as stage 2. That means NPO, IV fluid, IV antibiotics plus. In stage 3B, you have to take the child for exploratory laparotomy. So surgery is required, and you have to remove the perforated segment and do the anastomosis of rest of all. Plus you have to give blood products if the baby is bleeding. You may have to put the baby on mechanical ventilation if the baby is having life-threatening apneas. You have to give inotropes if there is shock, and so on, right? So that is about NEC. So what is the most appropriate management strategy is the question. Continue feeds with probiotic and close monitoring. No, we cannot do that. It's already stage 2 or definite NEC. Emergency surgical exploration, bowel resection is not required because till now, perforation has not occurred. Just there is pneumatosis intestinalis and portal vein gas. So it is stage 2 NEC for now. Contrast enema to evaluate for malrotation. We are not suspecting malrotation here. NPO, nasogastric decompression, and IV antibiotics is the treatment of choice for stage 2 NEC. So D is the best answer. Moving ahead, a 7-year-old boy with a history of moderate persistent asthma presents to the emergency department with severe shortness of breath, audible wheezing, and speaking only short phrases. So the child has acute severe asthma. So first let us discuss a little bit about the management of acute severe asthma, and then we come back to answer this question. So admission to ICU is indicated for which acute severe asthma or status asthmaticus patients? So it is also called status asthmaticus, just like status epilepticus. Okay, status asthmaticus. For patients with severe respiratory distress, poor response to therapy, and concern for potential respiratory failure and arrest. What do? You start supplemental oxygen, frequent or continuous administration of inhaled bronchodilator like salbutamol, or it is also called albuterol, and systemic corticosteroid therapy. You can either give oral. If the child is not able to take orally, you can give IV. Supplemental oxygen, of course, because SABA, nebulization with salbutamol, sometimes transiently lowers the oxygen saturation as well. Inhaled ipratropium may be added in those who are not showing response to inhaled salbutamol. Short course systemic corticosteroid therapy is recommended, and as we mentioned, oral and IV are equally efficacious. If the child is able to take orally, you give orally. If the child is too sick to take orally, you give IV. What else? If the child is not improving with this management, then you have to move to second line therapies like, you can use parenteral beta agonist, you can give magnesium sulfate injections, or you can give inhaled heliox, that is the helium oxygen mixture. Magnesium sulfate, of course, has got a narrow therapeutic index. If you're giving, you have to monitor the levels and cardiovascular status. Non-invasive positive pressure ventilation may be tried, and parenteral epinephrine or terbutaline sulfate may be used. And if required, of course, you have to go in for invasive mechanical ventilation. So coming back to the question, on examination, his saturation is 88%. That means low on room air, so oxygen will be required. Accessory muscle use is there, and he's already received 3 doses of nebulized salbutamol and oral corticosteroids. Despite this, there is minimal improvement. Which of the following is the most appropriate next step in management? Increase in inhaled corticosteroid dose is not going to help. You have given oral steroids, so you've already given systemic corticosteroids. So inhaled corticosteroid, increasing the dose is not going to help much here. Administer intravenous magnesium sulfate can be used because that is the next line when the child is not improving. Begin leukotriene receptor antagonist therapy. So this usually does not act immediately. It will prevent the further attacks of asthma or severe asthma, but it will not take care of that episode at that time. Start oral antibiotics, usually not required if there's no fever and if we are not suspecting, that the child has a bacterial infection or pneumonia, right? So administer intravenous magnesium sulfate is the best answer here. Moving ahead to our last question that we had from pediatrics. It's a crossover between pediatrics and dermatology, more towards dermatology for that matter. So an 8-year-old child is brought in with chief complaint of a rash that developed around the mouth and nose over the past 3 days. On examination, there are multiple erythematous papules and vesicles that have progressed to characteristic this honey crusted erosions. Now this honey crusted erosions, whenever you see, my diagnosis becomes impetigo. Okay, impetigo can be caused by staphylococcus, it can be caused by streptococcus. So essentially it is a bacterial infection with no associated systemic symptoms. If no systemic symptoms is there, then local antibiotic therapy is the treatment of choice. So mupirocin 2% ointment would be the treatment of choice here because there is no systemic involvement. If systemic involvement is there, systemic antibiotics would be required. So bacterial culture has been obtained, results are pending. Based on the clinical presentation, was the most appropriate empirical antibiotic therapy. So mupirocin 2% ointment is the treatment of choice in cases without systemic infection. Usually, so that is what is the best answer here. Oral amoxicillin or cephalexin will not be required if there are no systemic complaints. Topical bacitracin ointment is also usually not preferred, right? So these were the questions that were from pediatrics in this exam, and these are very, very important topics. This and the questions that we asked in the INI-CET Champions Exam 1 and the LRRs and the Rapid Revision Reignite. So those topics are very, very important for your upcoming INI-CET exams. Please revise those topics well and do not miss upon them. All the very best for your upcoming exams. Hoping that all of you who have worked really hard for this and have really dreamt day and night to achieve this are really able to achieve this and are able to go to one of the best medical institutes of our country. All the very best. God bless you.
Hi guys, this is your surgery faculty Dr. Pritesh Singh. Let's start the discussion. See the first question. A 28-year-old man is brought in after a high-speed motorcycle collision. He is conscious and you can see here GCS is 14/15. But patient is hypotensive and if you see the blood pressure is 90/60. So hypotensive patient is having tachycardia also. You can see the heart rate is 130 per minute and patient is having tachypnea also. Respiratory rate is 32 per minute. But the oxygen saturation is only 85%. You can see oxygen saturation 85% on room air. Clinical examination, this is very, very important, reveals absent breath sounds on the right. And you can see the shift of mediastinum means tracheal deviation to the left. If you see the X-ray, on this chest X-ray, you can notice that the right lung is collapsed and you can see that presence of air. You can notice here that there is presence of air and the lung is collapsed. So patient is having pneumothorax. What kind of pneumothorax? Because there is absent breath sounds. The patient is having absent breath sounds and there is tracheal deviation to the left side. It means patient is having tension pneumothorax. And in tension pneumothorax, see the question, what is the most urgent intervention required? Most urgent intervention required. So first thing, you can see here, patient is having hypotension, patient is having tachycardia, patient is having tachypnea, Oxygen saturation is 85% only. Absent breath sounds. All these findings are suggestive of tension pneumothorax. Tension pneumothorax, you can see the chest X-ray also. In tension pneumothorax, what is the initial step or the first step? First step is you have to put a wide bore needle in 5th intercostal space in adults, and in children 2nd intercostal space. Where exactly? In children 2nd intercostal space in mid-clavicular line, and in adults, see the age of patient 28 years old. So here it should be in 5th intercostal space in anterior axillary line. So the most urgent intervention is we have to insert a wide bore needle. So you can see 14 gauge needle, thoracentesis at which intercostal space? 5th intercostal space in anterior axillary line, and in cases of children it should be 2nd intercostal space in mid clavicular line. And what is the treatment of choice in tension pneumothorax? Doesn't matter whether the patient is an adult or a child. In both of these cases, we have to insert ICD. ICD means intercostal drain, and where exactly? In 5th intercostal space in anterior axillary line. So if you see the option B, 32 French chest tube insertion at 5th intercostal space in anterior axillary line. This is the treatment of choice, and this is the immediate next step. So most urgent step is this one, ICD needle insertion, and the treatment of choice is ICD insertion. Thoracotomy is not required in this case, and endotracheal intubation with positive pressure ventilation, this is also not required. So what is the correct answer here? The correct answer for this question is option A. Option A. Now see the next question, very easy. 35 years old woman, 6 months after Roux-en-Y gastric bypass. She presents with epigastric pain. There is nausea and vomiting after meals. CT shows dilated gastric pouch with contrast hold up at gastrojejunal anastomosis. There are no signs of bowel obstruction or leak. So here you can see that there is no signs of small bowel obstruction, there is no anastomotic leak. What is the most likely diagnosis and next step in the management? So let's discuss it again. What happens? This patient is having Roux-en-Y gastric bypass. After meals, she is having epigastric pain, nausea, vomiting, and there is dilated gastric pouch with contrast hold up at gastrojejunal anastomosis. See the diagrammatic representation. This patient is having RYGB. Can you tell me the full form? It is Roux-en-Y gastric bypass. In this case, you can see here, we are going to create a small gastric pouch and we perform this anastomosis. This is GJ, gastrojejunostomy. What's the problem here? The contrast is held here, and what? This gastric pouch is dilated. If this gastric pouch is dilated, after meals patient is having nausea, vomiting, and what? There is dilated pouch. Here you can see the collection of contrast. It means at this anastomosis, what's the problem? Obstruction. And why there is obstruction at this anastomosis, guys? It's because of stricture. So what is the problem here? There is stricture at gastrojejunostomy anastomosis. Stricture at the gastrojejunostomy anastomosis. Clear? So see the question again. If you see the question again, this patient is having what? Anastomotic stricture. And how you can dilate this stricture? We can go for endoscopic balloon dilatation. So what is the correct answer? Option A. Now see the option B. Internal hernia, and we have to go for exploratory laparoscopy with hernia repair. No. If patient is having internal hernia, what happens? There will be signs and symptoms of small bowel obstruction. Here, what is dilated? Gastric pouch is dilated. It means obstruction is just beyond the gastric pouch. So this is ruled out. Dumping syndrome. In dumping syndrome, vomiting is not there. There is no dilated gastric pouch. This is also ruled out. So in dumping syndrome, what's the problem? After meals, when the hyperosmolar content is dumped into the proximal part of small bowel, patient is having early dumping or late dumping. Why? Because of hyperosmotic or hyperglycemic component. Okay. This patient is not having marginal ulceration, because in this ulceration also, if the patient is having ulceration, the gastric pouch is not dilated. So here, patient is having epigastric pain, nausea, vomiting. There is dilated gastric pouch with contrast hold up in gastrojejunal anastomosis. So correct answer is patient is having anastomotic stricture. And in this case, how to manage? We can go for endoscopic balloon dilatation. So correct answer is option A. Now see the next question. In this question, you can notice that a 70 years old male, see the age, 70 years old male, known case of, he's having known 5.5 centimeter abdominal aortic aneurysm, presents with, see the problem, sudden severe back pain, means most probably the aneurysm has ruptured. If you see the blood pressure, 85 by 50 mmHg, patient is having hypotension, heart rate 110 per minute, tachycardia, CT angiogram below, you can see here in this CT angiogram, you can see there is contained rupture. So in this case, you can notice that this is aorta, and here you can see that this patient is having what? Contained rupture. So this patient is having contained rupture. What is the most appropriate immediate management if anatomy is suitable? In this case, what is the problem? Patient is having contained aortic aneurysm rupture. So in this case, what is the preferred treatment? In these cases, we are going for EVAR, endovascular aneurysm repair. Right? There is another repair which can be done, emergency open aortic repair via transperitoneal approach, but this is not preferred in cases of contained rupture. Balloon occlusion of aorta, delayed repair, no, delayed repair is not done because it's life-threatening situation. Medical management is not indicated in this case, so correct answer is option B. Now see the next question, very easy question. Which of the following statements are correct about negative pressure wound therapy? You know what is the other name of negative pressure wound therapy? This is also known as VAC. So guys, can you tell me the full form? This is vacuum assisted closure. So this is negative pressure wound therapy or vacuum assisted closure. Okay, first option, it decreases bacterial load, because here we are going to create suction. How much negative pressure has been applied in this case? We are supposed to apply minus 125 mmHg. So what happens? It is going to decrease the bacterial load. So this is correct. Pressure of minus 125 mmHg is used. That is also correct. Since it is having suction, so because of that, it is going to increase the blood flow in the wound and it is going to suck the secretion. So what happens? It reduces edema. So it reduces edema, increases the blood flow, so it forms more granulation tissue. That is also correct. Dressing can be done after 5 to 7 days. That is also correct. And it can be vacuum. We are going to apply the vacuum or negative pressure. It can be applied continuously or it can be applied intermittently. So this is also correct. So for negative pressure wound therapy, all 5 options are correct. 1, 2, 3, 4, 5. So which of the following is correct answer, guys? A. 1, 2, 3, 4, 5, all of these are correct. So correct answer is option A. Okay. Now see important questions related to negative pressure wound therapy, which is also known as VAC, vacuum assisted closure. Mostly it is asked in the form of image based question, where the image will be given like this. In this case, you can notice that there is a tubing applied here, black colored seal dressing, and you can see there is seal dressing. So it is applied with sealed dressing. And you can see the tubing, guys, this tubing, this is used for creation of vacuum. So this is for creation of vacuum. So this is negative pressure wound therapy. The chronic wounds which are not healing, for those wounds we are using negative pressure wound therapy. But there are certain contraindications. And can you tell me what are the contraindications of negative pressure wound therapy? How to remember? Mnemonic is MUNNA. So M, whenever there is malignancy in the wound. U, untreated osteomyelitis, non-enteric and undrained fistula, and N, necrotic tissue with eschar. So these are the contraindications of negative pressure wound therapy. Otherwise, in most of the chronic wounds we are using vacuum assisted closure, which is also known as negative pressure wound therapy. Now see the next question, very easy question. 6 months old infant, age 6 months. Patient presents with chronic constipation. There is abdominal distension and delayed passage of meconium. So you got the hint. What's the diagnosis? Most probably Hirschsprung's disease. Now see, contrast enema reveals transition zone consistent with short segment Hirschsprung's. So patient is having short segment Hirschsprung's disease. Infant is otherwise stable and there is no signs of enterocolitis. What is the most appropriate initial management? Let me discuss. There are 2 types of Hirschsprung's. You can see this is the first one. The patient who is having short segment Hirschsprung's. Can you see this? And can you see the option B? This patient is having long segment disease. Tell me which patient will be more symptomatic and which patient will present earlier. Suppose this is A, this is B. So if you see B, in B, the longer segment is involved and it is more narrow. The severity of narrowing is more. That's why B patient will be more symptomatic, presented at early stage. In these cases, what we do, here we perform colostomy and then we go for end-to-end repair or definitive operation. But if patient is having this kind of short segment Hirschsprung's disease, here extended myectomy is sufficient. So patient is having short segment Hirschsprung's. So what is the most appropriate initial management? Most appropriate initial management is extended myectomy. If patient is having long segment disease, for long segment disease, we are going for what? Temporary colostomy followed by definitive pull through. Antibiotics, only antibiotics is not having any role because we have to go for surgery. And watchful waiting, no, we are going for surgery because this patient is symptomatic and there are signs and symptoms of obstruction. So what is the correct answer here? Option B. Let me tell you important points related to management of Hirschsprung's. We discussed already patients who are having short segment disease. We discussed what we are going for, extended myectomy. And if patient is having long segment disease, what we are going for? First, create a temporary colostomy. After that, we have to go for definitive operation. So for long segment disease, temporary colostomy. Patient is going to gain some weight, general condition of patient is going to improve, and then go for definitive operation. Guys, you have to remember what? The names of procedure. And see the names. Definitive procedures are Swenson, Duhamel, Sauvé. So here you can see in this image, this is the disease segment, right? So we are going to excise this disease segment and we are going to perform the anastomosis with healthy proximal and distal segment. So initially go for colostomy followed by definitive operation. Okay. Let's see the next question. Again, it's easy question. Full term newborn presents with problem non-bilious vomiting and patient is having abdominal distension soon after birth. X-ray shows double bubble sign. First, can you tell me double bubble sign is seen in which condition? It is seen in duodenal atresia also. It is seen in annular pancreas also. In both, which one is having bilious vomiting? Which one is having non-bilious vomiting? You know that duodenal atresia, the obstruction is distal to ampulla. Here, what kind of vomiting? Bilious. And if patient is having annular pancreas, so the patients who are having annular pancreas, in these cases the obstruction is proximal to ampulla. So what kind of vomiting? Here, non-bilious vomiting. What kind of vomiting is there? It's non-bilious. Got it? And further evaluation confirms that patient is having annular pancreas encircling the duodenum causing obstruction. The baby is otherwise stable with no major anomalies, no other anomalies. What is the treatment of choice? So you know that for both duodenal atresia as well as annular pancreas, for both we go for DD. So what? It is DD. DD means duodeno-duodenostomy followed by DJ, duodeno-jejunostomy. And there is another similar condition known as superior mesenteric artery syndrome. In superior mesenteric artery syndrome, what is the treatment of choice, guys? You know it's DJ. So here what we are going for? We are going for DD, duodeno-duodenostomy. Got it? So correct answer is option B, DD, duodeno-duodenostomy. Important points related to annular pancreas. Here you can see where is the obstruction, guys? Yes, proximal to ampulla. That's why what kind of vomiting? Non-bilious. Non-bilious. And another important point in duodenal atresia, here is DA. Duodenal atresia obstruction is distal to ampulla. So here what kind of vomiting? You know, bilious. Bilious. And in both there is double bubble sign, and in both the treatment of choice is DD followed by DJ. There are important questions related to single bubble, double bubble, triple bubble, and you already know single bubble, it is seen in hypertrophic pyloric stenosis. Can you see? This is the distended stomach. Can you see this image? So you can notice that this is distended stomach, and here the gas in fundus, and here in the first part of duodenum. So this is double bubble, and we discussed that it is seen in annular pancreas and duodenal atresia, and triple bubble, it is seen in jejunal atresia. Got it? So these are the important questions. Okay. Now see the next question. This is very important and very, very easy question. Which of the following features are part of Reynolds pentad? First tell me, what are the components of Charcot steroid? It's pain, jaundice, fever. And what is Reynolds pentard? It's Charcot striae plus shock plus mental status changes. So you can see guys, what is Charcot striae? First, Charcot's. So Charcot striae, patient is having pain, jaundice, fever. So pain, there is jaundice. So pain, jaundice, fever. Clear? And what is Reynolds pentard? Apart from Charcot striae, you have to add what? Shock, patient is having hypotension, plus mental status alteration or mental status changes. So mental status alteration, got it? Mental status alteration. Okay. So these are the components of Charcot striae and Reynolds pentard. Now see here, in Reynolds pentard there is altered mental status, yes. Vomiting is not the component, jaundice is the component, hypotension is the component, diaphoresis is not the component. So here you can see 1, 3, 4. These are the components of Reynolds pentard. So what's the correct answer here? Correct answer is option D, that is 1, 3, 4. Which of the following is correct regarding nerve grafts? Let me tell you something about nerve grafts first. So nerve grafts, which is the most commonly used nerve for the grafts? Guys, it's sural nerve followed by antebrachial cutaneous nerve. So it's the sural nerve followed by antebrachial cutaneous nerve. And in antebrachial cutaneous nerve, which one is preferred? Medial followed by lateral. There can be other donor nerves which can be used. We are using superficial radial nerve or greater auricular nerve, especially when there is injury of facial nerve during parotidectomy. The gold standard for nerve repair, we are using sutures. So it's the microsurgical sutures. Why? Why it's gold standard? Because it's going to offer, it's microsurgical suture because it's going to offer superior tensile strength and reliability as compared to fibrin glue alone. Means we can go for fibrin glue also, usually in combination, but the gold standard is microsurgical sutures. That's for nerve repair. You got it? Now see the questions. Nerve grafting is used for peripheral nerves is correct. This option is correct. Next, it is used for surgical repair of facial nerve palsy. That is also correct. The most common nerves are saphenous nerve and anterior interosseous nerve. No, it's sural nerve. It's not saphenous. We discussed just now. It's sural nerve. Sural nerve. And the nerve graft can be reconstructed only with fibrin glue. No, it can be reconstructed with fibrin glue, but preferred is microsurgical sutures. This is the gold standard. Microsurgical sutures, these are gold standard. We can use fibrin glue also. So option 4 is also wrong. So 1 and 2 are correct, 3 and 4 are wrong. So here correct answer is option B, 1 and 2. See this question, 45 years old woman with invasive ductal carcinoma. So this female is having breast cancer. What is the stage? T2 N0 M0, tumor size is 3 cm. She underwent breast conservation surgery with clear margins. So margins are negative. Clear margins. Sentinel lymph node biopsy is also negative. What is the most appropriate adjunctive therapy? So this patient is having early invasive breast cancer. And what is preferred? Breast conservation surgery. So we go for breast conservation surgery plus sentinel lymph node biopsy. Since you have to conserve the breast, there is high risk of recurrence. So what happens? You can see here. This is the patient. Imagine this is the breast. You can see here, this is the nipple areola and here is the lump. Usually we go for lumpectomy or we can go for wide local excision or we can go for quadrantectomy. And after this breast conservation surgery, since there is high risk of recurrence, that's why we give radiotherapy. So after this breast conservation surgery, what should be given? Radiotherapy. So see option A, radiation therapy to the breast only without regional nodal irradiation. That's correct because lymph nodes are negative. Chemotherapy followed by radiation therapy to the breast and nodes. No, here chemotherapy is not indicated. Endocrine therapy alone, if hormone receptor is positive, not required. No adjunct therapy required with negative lymph nodes. This is incorrect. So in breast conservation surgery, we give what? Radiotherapy. So what is the preferred answer here? Option A. See the next question. And this is very important. It was asked multiple times. This question is in trend. It's a trending question. It's very, very hot question. Which is the correct sequence for the correction of hypospadias? So guys, it's very easy to remember. See the mnemonic. Mnemonic is do your myoplasty with GPS. It is do your meatoplasty. Clear? So it is do your meatoplasty with GPS. So D, that's degloving. D, that's degloving. O means straightening of penis, that is orthoplasty. So this is orthoplasty. Okay. After that UR, that is urethroplasty. What? This is urethro. So this is urethroplasty. After that meatoplasty. After that G, granuloplasty. This is granuloplasty. After that P, that's pinoplasty. It's pinoplasty. After that S is scrotoplasty. Scrotoplasty. Okay. So degloving is there? No, it's not there. After that orthoplasty is there. So first will be 3. Do your urethroplasty is there. So it is 1. Do your meatoplasty. So you can see meatoplasty is there. So that's 2. After that granuloplasty 4. So it is 3, 1, 2, 4 guys. So what is the correct answer? Do your meatoplasty. So 3. Do your meatoplasty. So 3 orthoplasty. After that urethroplasty. After that meatoplasty. After that granuloplasty. So it is 3, 1, 2, 4. So correct answer is option B. It is 3, 1, 2, 4. Clear? So it is option B. Now see this question. A 2 weeks old male infant presents with persistent projectile non-bilious vomiting. You have the clue that this patient is having hypertrophic pyloric stenosis. There is poor weight gain. Physical examination reveals palpable olive-shaped mass in the epigastrium. Abdominal ultrasound shows an elongated and thickened pyloric muscle measuring 20 mm in length, 6 mm in thickness, consistent with hypertrophic pyloric stenosis. And you know what's the treatment of choice? We go for pyloromyotomy, Ramstead-Friedet pyloromyotomy. This Ramstead-Friedet pyloromyotomy can be done laparoscopically also, and it can be done by open approach also. Yes, both of these are having similar results, but tell me which one is preferred. Laparoscopic pyloromyotomy is preferred. Why? Because there is faster recovery, shorter hospital stay, and these patients are having better cosmetic results. So both option A and B are correct, but which one is preferred? Obviously, laparoscopic pyloromyotomy, this is preferred. Why it is preferred? Because there is faster recovery. So these patients have faster recovery, there is shorter hospital stay, and patient is having better cosmetic results. What's the name of surgery? You know, it's known as Ramstead's. So this is Ramstead's Friedet. So it's Ramstead-Friedet pyloromyotomy. Ramstead-Friedet pyloromyotomy. Pyloromyotomy. It can be done laparoscopically also. It can be done by open approach also. Nowadays, which one is preferred? Laparoscopic approach. So correct answer is option B. See the next question. Very, very easy. Match the features seen due to compression of following structures in cases of thyroid swelling. So guys, you know, if there is compression of trachea, can you tell me what is the symptom? Obviously dyspnea. So trachea, dyspnea. Esophagus, obviously dysphagia. Sympathetic chain or cervical sympathetic trunk, Horner syndrome. And recurrent laryngeal nerve compression, obviously what will happen? Hoarseness of voice. So you can see it's 1C, 2D, you can see 3A and 4. It is 3B and 4A. 3B and 4A. So CDBA, it is CDBA. So what is the correct answer here? It is CDBA. So correct answer is option B. Clear? Now see the next question. Again, very, very easy. Though integrated question, sometimes discussed in medicine, sometimes in surgery. See the problem. Echocardiography of 65 years old male who presented with progressive external dyspnea. What else? Presyncope. And it reveals in this patient there is severe aortic stenosis. It is characterized by the valve area of 0.6 cm per square. Mean transvalvular gradient of 55 mmHg and left ventricular ejection fraction of 30% only. His Society of Thoracic Surgeons risk score is calculated to be 8%, indicating high surgical risk. Considering this, his clinical presentation and comorbidities, which of the following is most appropriate intervention? So patient is high risk, age 65, high surgical risk patient. So in these cases, what is the preferred appropriate intervention? We go for transcatheter aortic valve replacement. So this is TA. We are going for transcatheter aortic valve replacement in this patient who is having severe aortic stenosis. Clear? So what is the correct answer? Correct answer is option C. Now see the next question. Very easy question. 55 years old man. Patient is having end stage liver disease. MELD score is 28. Being evaluated for liver transplantation. He has history of hepatocellular carcinoma, HCC. You know what's the problem with HCC? HCC is having multicentric and bilobar disease in majority. So what happens at the time of presentation, multiple nodules or multiple tumors are there in the liver. And multicentric bilobar disease, usually it's a contraindication for liver transplantation. But there are exceptions in which you can perform liver transplantation. And what is the name of that criteria? That's Milan's criteria. So you can see Milan's criteria. If patient is having single tumor less than or up to 5 centimeter, up to 3 lesion each less than 3 centimeter, no extra hepatic or vascular invasion. So since there is exceptions, in this case we can go for liver transplantation. So which of the following is most appropriate transplant allocation consideration? Standard MELD score prioritization without modification? No. There must be some exception. And what exception? Patient is having MELD exception. So here patient is having MELD exception. The criteria of liver transplantation in HCC, that is Milan's criteria, single tumor up to 5 centimeter, number of tumors 3, less than or up to 3 centimeter, and there should not be any extra hepatic or vascular spread. So in this case, there are MELD exception points for HCC. Reduced priority due to malignancy history? No. It's an indication for liver transplantation if patient is going to fulfill the Milan's criteria. Automatic exclusion due to cancer history? No, this is also incorrect. So what is the correct answer here? Option B. So option B is correct answer. Now see this question. A 25 years old male, see the age 25 years, brought to the emergency department following high speed motor vehicle accident. Paramedics report an initial brief loss of consciousness. So there is LOC at the scene, followed by period of alertness and coherent conversation, and then rapid decline in his GCS score. So patient was unconscious, then patient became conscious, again patient is unconscious. So guys, you know that which interval? Lucid interval is positive. So this patient is having lucid interval. An important thing that there is rapid decline in GCS score, right? CT is given below, and you can see in the CT obviously patient is having extradural hematoma. So this patient is having EDH. Given the clinical presentation and CT finding, what is the most appropriate immediate management? In this case, you have to drain the hematoma. We have two options, burr hole, and we can go for craniotomy. Whenever patient is young, the surgical risk is not too much, and you want to go for rapid decompression. Yes. Or patient who is having large hematoma. So for rapid decompression, if there is rapid decline in the GCS score, large hematoma is there, in such cases we go for craniotomy. If patient is elderly having high risk, in those cases we can go for burr hole. So here what is preferred? We have to drain it via craniotomy. So see option 1 or option A. Intracranial pressure monitoring with medical management? No, we have to drain it. Burr hole placement for decompression? Here rapid decompression is required, patient is young, so this is not correct. Emergency craniotomy for hematoma evacuation? Yes, it's correct. Conservative management is not having any role, so this is also incorrect. So correct answer for this question is option C. Now see how to decide whether we have to go for burr hole, whether we have to go for burr hole or craniotomy. Okay, so here whether we have to go for burr hole or craniotomy, right? So burr hole, here a small hole is drilled into the skull to drain fluid, blood or clot. What is the good thing about burr hole? That it is less invasive, smaller or less complex hematoma. Smaller or less complex hematoma. some chronic SDH, in that case it is preferred, and usually it's done in the patients who are elderly or high risk, who may not tolerate general anesthesia, right? But craniotomy here, a larger section of skull is temporarily removed for wider access and then it is replaced, since it's more invasive. So in which cases we are going to prefer larger hematoma, there are solid clots or brain tumors or aneurysm. It may be done for the patients who require immediate surgery for rapid decompression, right? So obviously burr hole will be having lower risk of complications and craniotomy contains higher risk of complications. So this is how you can decide in which case you go for craniotomy and in which case you are going for burr hole. Another very important question, 30 years old teacher underwent parotidectomy, following which she developed lower lip paralysis, right? This probably occurred because of an injury to which of the following structure? So the patient is having lower lip paralysis. It means the nerve which is going to supply the lower lip and chin, that is injured. And what's that nerve, guys? You know which nerve is going to supply the lower lip and the chin? It is mandibular branch of facial nerve. So it's the mandibular branch of facial nerve which is going to supply the lower lip and chin. Muscles of lower lip and chin. Clear? So what is the correct answer here? Correct answer is option D. Option D. See important points related to this marginal mandibular branch of facial nerve. We discussed that it is going to supply the muscles of lower lip and chin. So what are those muscles, guys? Tell me the names. Depressor anguli oris, depressor labii inferioris and mentalis muscle. What is the function of these muscles? It is going to pull the corners of mouth down and drawing the lower lip down. So what is the nerve injured whenever there is lower lip paralysis? It's the marginal mandibular branch of facial nerve. So these were the questions, guys. Thank you very much.
Okay guys, welcome to the medicine solutions part. Starting with the first question, we have this guy where the first medical contact was obtained 90 minutes ago. There is ECG findings of ST elevation in 2-3 and AVF. So this is a case of inferior wall MI. He has mentioned that the nearest PCI facility is 45 minutes away. So the basic point is that the transit time in this case would be 90 plus 45. That is going to be 135 minutes and this will exceed the guidelines. The guidelines are that we should transfer the patient to a PCI equipped hospital and provided the time taken is less than 120 minutes. But in this particular case, you can see that the total time that would be required is 135. So I am ruling out option number A. And second, transferring somebody with a blood pressure of 80/50 is really not a good idea. So I should treat him at the place where I am. And for treatment, I have two options. Either I can deploy a balloon pump or I can go for fibrinolytic therapy. Now the point is, if I deploy a balloon pump, that will not treat the cause. You see, you treat the cause, then the manifestation of this or the cause of hypotension would be treated. So therefore, fibrinolytic therapy would be preferred over deploying a balloon pump, which will anyway take time. And option number D was a dummy choice that could easily be ruled out. So first you had to know two concepts here. First is that how much time frame should you be taking care of whenever you want to transfer somebody to a PCI equipped hospital. The total transit time from first medical contact should be under 2 hours, and in this case it was 135 minutes. So that's point number one. And second is, if there is a combination of hypotension and the cause also is given, then first treat the cause and the hypotension part will begin to resolve in this case. Let's move to the next one, where we have a patient of type 2 diabetes with heart failure. So this could be ischemic cardiomyopathy because he has mentioned an ejection fraction that is very low. The patient is already on the standard treatment for heart failure. ACE inhibitor, beta blocker, aldosterone antagonist, SGLT2 inhibitor is already there. Now he says echocardiography is showing a low ejection fraction. So my patient is having a heart failure with a reduced ejection fraction. There is a dilation of the ventricles also, because of which there is a functional mitral regurgitation and a left bundle branch morphology in ECG is given, which tells me that both ventricles are not working in tandem. So what should I do for this patient? One is giving SGLT2 inhibitor further will not help because already we are giving to the patient. So increasing the dose I think will not be a very good idea. Mitra clip is not recommended for functional variety of mitral regurgitation. The point in this case is that the mitral regurgitation is because of the dilation of the cardiac chamber. So the annulus is getting dilated. So we need to treat the heart failure component. Now waiting for cardiac transplantation would again be very, very long. So what is recommended is the CRT. CRT basically means that we will ensure that the two leads of our device will make both ventricles fire at the same time so that the cardiac output of the patient can improve. So cardiac resynchronization therapy is used for medically refractory congestive heart failure. That's the concept behind this question, medically refractory congestive heart failure. And the reason for that is ischemic cardiomyopathy, which can occur in diabetes because diabetes contributes to coronary artery disease. Next, we have a post-operative patient with breathing difficulty, chest pain is given, Wells score is given, a D-dimer issue, and then CT angiography is showing pulmonary emboli. So initially I thought he's putting me a standard question where I have to do thrombolysis in a patient, but then you can notice that he's hemodynamically stable at the moment. So what should I do? Should I do thrombolysis? No. Thrombolysis done if the BP is crashing. Now in this case, like because patient is hemodynamically stable, I can manage with anticoagulation. Now for the anticoagulation part, like agrobatin is used for heparin-induced thrombocytopenia. When it comes to enoxaparin with warfarin bridging, I mean like enoxaparin is low molecular weight heparin and we do not need a warfarin bridging with it. So that's again like a dummy thing to be remembered. So what is recommended in this particular case is start him on like the newer oral anticoagulant drugs, that is like rivaroxaban, which will be where we'll be able to manage the patient aggressively. Moving to the next one, we have this patient with systemic lupus erythematosus. He says, how do you manage lupus nephritis and so many other manifestations like neuropsychiatric profile, then hematological manifestations? So for these patients, especially lupus nephritis, if it's gonna be at or before stage 4, we'll give steroids when the patient makes sense. And along with that, steroid sparing agents like mycophenolate can be used. Most of the time in SLE, one of the major drugs that are used are mainly 1 and 3, that is prednisolone and then mycophenolate. So the correct answer in this case is option number B. Next, we have a 45-year-old guy with type 2 diabetes who's having sweating, tremors and confusions after meals. His blood glucose during the time when he is having this neuroglycopenia symptoms is only 45, and then he's mentioned high insulin and C-peptide levels. Well, the answer is not 72-hour fasting test because that's what is used for diagnosis of insulinoma. He himself mentioned that patient is having type 2 diabetes. So the answer, the disease process is not changing. What is happening in this guy is that probably the insulin that we're giving to this patient or the drugs which are being given to increase the levels of insulin, which are insulin secretagogues like sulfonylureas, might be given in a very high dose. When it comes to option number C, oral glucose tolerance test, it is used for diagnosis of diabetes. So is HbA1c. So by exclusion, the answer is a mixed meal tolerance, by which we can evaluate like whether his blood sugar is rising after taking a particular amount of carbohydrates and whether the drugs that we are giving to this patient are disproportionately high. Now here the trouble with this question is that C-peptide levels ideally would be less in an individual in whom excess amount of insulin is being administered due to feedback mechanism. But when we look at the options, the only thing that fits the bill for this particular question is option number B. But yeah, if somebody is taking exogenous insulin, then the values of C-peptide are bound to fall. Next is hepatitis B virus antigen and its clinical significance. So it's a pretty straightforward one. Surface antigen is one of the earliest serological evidence of infection. So 1 will match with option number D. For core antigen, it never appears in the blood. So 2 will be C. I think that is sorting me out. When it comes to E antigen, it's a marker for replication, and X antigen is gonna be inhibiting CD95. So this increases the risk of hepatocellular carcinoma in this patient. So the correct answer for this is option number A. Especially like what I want you to remember for this is like why do you have is an increase of liver cancer is because of inhibition of apoptosis that is done by the hepatitis B X antigen. So we are sorted for this one. Let's look at the next one where we have this diabetic patient with chronic kidney disease. The eGFR is really down, 18 only. So he is at the threshold where transplantation or dialysis needs to be planned in this chap ASAP as soon as possible. possible. And then he says, how would you manage this case considering that his hemoglobin is less and the ferritin values have been given to be 200, saturation is about 18%. So what I need to do for this guy is, first I need to replenish the iron stores. Now in a guy who's gonna be reaching that particular stage where especially like the uremia component can be severe, vomiting can be severe, giving iron supplements would not be a very good idea. So for patients who are like nearing the need for dialysis, it is recommended to give IV iron for these patients, and then subsequently erythropoietin based agents like darbepoetin can be started for this patient. So the correct answer for this is option number C. Why not start with option number B directly? The point is that erythropoietin stimulating agents will not work in a setting of iron deficiency, which is very common in these patients. And then at the same time, blood transfusion will rather make these patients transfusion dependent. So the correct answer is C. Next, I have a patient of hepatitis B who's being evaluated on the basis of MELD 3.0 score. So for MELD 3.0, I have bilirubin, I have INR. I don't have a calcium. It is creatinine. It is creatinine, and I take it into consideration albumin as well. So the answer will turn out to be option number A for this one. Next, we have a patient with fatigue and splenomegaly, especially like, a person who's having lymphocytosis 70% with WBC being elevated. And then when you read this profile, CD19 positive, CD5, CD23, you know that you're dealing with a case of chronic lymphocytic leukemia. So for this chap, I need to do a CT chest abdomen for staging. I want to check for the lymphadenopathy, like we're talking about rise staging in this particular case. So one, the diagnosis is very clear, and subsequently I want to see how many groups of lymph nodes are involved in this case. So the answer would be A. Coming to this question, occupational exposure to birds can cause hypersensitivity pneumonitis. I mean, that's okay. That's a type 4 hypersensitivity. The histopath finding is a non-caseating granulomas also. So both statements are okay, but it's not giving a reason why. It's not mentioning any antigenic stimulation. It's not mentioning regarding the clinical prediction rule. So it's not explaining the why component, which is why the correct answer in this case is option number B, that the reason is not the correct explanation of the assertion. Now we have this chap with tuberculosis. He came with pedal edema, abdominal distension, neck veins are prominent, x-rays given. So there's like, increased cardiothoracic ratio. This looks like to be a patient who's having like a pericardial effusion, which could be resulting in development of a cardiac tamponade. I mean, why I'm saying cardiac tamponade is because the neck veins in the patient are prominent. So that means that the pressure on the heart is pretty substantial. Now it says which is correct about this case. So pulsus bisvariance is a feature of hypertrophic cardiomyopathy. Small sign is not seen in patients of cardiac tamponade because it's a non-pulsatile elevated JVP. We do get a hypotension and pulsus paradoxus and fine crepitations. Well, lots of time in these patients, pulmonary edema may not be present because this is not a case of heart failure. No, it is rather obstructive shock that is occurring, which is why the correct answer to this question is option number C. Next, we have an immunocompromised patient with pneumonia and multiple suspicious skin lesions. He mentions that broad-based budding. I mean, the moment you read about that broad-based budding, you know that you're dealing with a case of blastomycosis. And the chap is having both pneumonia as well as skin lesions present. So it's a disseminated disorder. Now, considering it's a disseminated disease and a severe one, what I'll use for this patient initially will be liposomal amphotericin B, and then I'll follow it up with itraconazole for management of this case. So the correct answer here is option number C. We have this patient who came with acute kidney injury, hemoptysis, sinusitis. So whenever you read about hemoptysis and kidney injury together, you think in terms of good pasture, but then there is sinusitis also given. There are RBCs also described with C ANCA. So the diagnosis of this patient is granulomatosis with polyangiitis. The drug of choice for this condition has changed, and the drug of choice for management of the condition is rituximab. But here is asking what is the initial treatment. So we still start treatment with cyclophosphamide, and then the drug of choice for management of this patient is rituximab. So DOC part, if it was asked, I would have answered it as rituximab. Otherwise, the answer is straightforward, cyclophosphamide. Next is a patient of chronic hepatitis C with ascites and edema. So that means that there is like a liver damage that has occurred substantially. The alpha-fetoprotein levels are turning out to be elevated. And yes, he has mentioned very rightly, I mean, there's a hypervascular lesion in the right lobe. So you are suspecting liver cancer. So he says, what would you do in this patient for staging? So we'll do a CT scan. We're can do it on the CT, chest, abdomen, and pelvis. That would be like the initial methodology for staging this particular cancer. Yeah, if it was like a lung tumor where there's a micromets happening, I would have done a PET CT for this patient. But considering hepatocellular carcinoma, predictable spreads, we will be doing a contrast in our CT, abdomen, and pelvis for this chap. Now we have a lady who's having heat intolerance, palpitations, increased anxiety, and weight loss in spite of appetite. I mean, every time we read about like weight loss in spite of increased appetite, and then there's that heat intolerance written. I mean, the question is screaming out loud that I'm Graves' disease. Even the TSH of the patient is literally undetectable with the elevated free T4 level. So he's saying, what will you do for this case? So in all of these patients, first objective is to make them euthyroid, and therefore we will be giving methimazole and giving beta blockers for management of this patient. Obviously, propylthiouracil will be a drug that would be considered if he was talking about pregnancy or he was talking about like the breastfeeding domain. The treatment of choice is radioactive iodine, but the initial treatment is methimazole with a beta blocker. Next, we have a patient who's having a splenomegaly with a pancytopenia, and then he is himself mentioned regarding that hairy cells being demonstrated. So here is a leukemia, for management of which among the options here, the most appropriate one is cladribine, which is the preferred drug for management of HCL. Then is ARDS following a severe pneumonia. His described tidal volume, ventilator parameters are given. He says, what is the next step? So if I look at the options for this particular guy, he is going into severe ARDS. He's going from moderate to severe ARDS. That is, severe is gonna be a PaO to FiO2 ratio of less than 100, and here it is turning out to be 120. So he's gonna land up into a worse situation. So what I can do in this patient is manage the patient with the prone positioning for refractory hypoxemia. The correct answer in this case is option number D. If I increase the tidal volume further, it can actually contribute to barotrauma. So I don't want to take the chance of barotrauma. If I increase the PEEP further, it will decrease the venous return in this case. So the most appropriate thing for this, and FiO2 I'll not decrease. So the ventilatory strategy would be add prone positioning for the refractory hypoxia component of this patient. Thank you so much for your patience and hearing me out.
Hello friends, this is Dr. Nikita here. So we are going to discuss the radiology questions of INI-CET Champions exam. So the first question that we have here is, we have in the question a 55-year-old hypertensive male, headache is there, GCS is 12/15, the blood pressure is high, and the CT is shown. So look at the CT here that you are seeing the hyperdense area. Now this hyperdense area here on a non-contrast CT is acute hemorrhage. You can see the surrounding hypodense area which suggests edema. This is the midline, right? So this is the actual original midline, and this is the midline currently. So there is a midline shift that we are seeing. There is intraventricular extension of the hemorrhage that we are seeing. So this hemorrhage is having a mass effect causing midline shift, and that is why we need to evacuate this hematoma. Right. So in general cases, what we do is decompressive craniectomy with hematoma evacuation. But now what is preferred is minimally invasive techniques are preferred. So a better answer would be stereotactic hematoma evacuation via minimally invasive approach is what will be done. If that is not in the options, then you will go for decompressive craniectomy. Right. So wherever the facility is available, we will go for stereotactic hematoma evacuation so that the mass effect is gone. Going to the next question here. A 65-year-old man has massive lower GI bleed and hypotension. Colonoscopy, there is fresh blood, but no active bleeding source was identified. So on angiography, there was active extravasation from a branch of the superior mesenteric artery. So what is the most appropriate immediate interventional management? So if you look at this image here, this is a DSA image, or angiography image that we are seeing here. And you can see this vessel here with the contrast coming out, the extravasation of contrast from a branch of superior mesenteric artery. So we will do the selective embolization of this branch so that the bleeding stops from here. Right. So super selective coil embolization of the bleeding vessel should be done. We are seeing the active bleeding source. We have identified that. So we shall embolize this and we shall stop the bleeding. The selective coil embolization is what will be the answer here, not the main trunk, the main SMA trunk. Right. So this is going to be the answer here. Next one, a 40-year-old patient with history of corticosteroid use has hip pain. Whenever you have steroid patient with hip pain, you start thinking of avascular necrosis. MRI shows a subchondral lesion with a high signal intensity inner border, a low signal intensity peripheral rim, and on X-ray there is crescent shape opacity. So what is the characteristic sign that you see on MRI that has been asked? So on MRI in avascular necrosis, the sign that we see is double line sign. So this is an image that I've added to demonstrate this double line sign. So in the area of the AVN, there is this outer dark border, inner bright border. The inner bright border represents the granulation tissue and the outer dark border represents the fibrosis and sclerosis. So this is the double line sign that you are seeing here, which is basically the high signal intensity inner border that we are seeing and low signal intensity peripheral border. So granulation tissue and the sclerosis and fibrosis. So this is what you see, double line sign. We do see crescent sign in AVN. That crescent sign represents a subchondral fracture, but that's seen on X-ray as well. It's not particularly for MRI. So the answer here, which is mentioned here, this is double line sign. Going to next one, a 55-year-old patient with chest pain, cardiac catheterization undergoes, and there the fractional flow reserve is 0.75. That means it is reduced, and the image of the coronary angiogram is given here. So what are we seeing here is this is the area which is showing the narrowing, right? The stenotic area that we are seeing there, and the fractional reserve, flow reserve is also reduced. It is less than 0.8. So we need to revascularize this. So what do we do is percutaneous coronary intervention. Percutaneous coronary intervention with drug-eluting stent, which will prevent the restenosis. So in emergency, what do we do is PCI with drug-eluting stent to restore the vascularity. So the answer here is going to be PCI with drug-eluting stent is what should be done. Not just medical management, not just repeat the angiography. We are seeing a significant stenosis with the fractional flow reserve decreased. So we need to do PCI with drug-eluting stent. Going to next one, 70-year-old male patient has sudden onset severe abdominal pain. There is characteristic imaging sign which is shown here. So what is the most appropriate immediate management? So what are we seeing here is there is this whirlpool sign, the twisting that you are seeing suggestive of volvulus. You know that the volvulus will lead to the back pressure and lead to the proximal small bowel loops dilatation. You can see the air fluid level. So there is this volvulus, the whirlpool sign, along with the small bowel loops getting dilated. So that means we need to treat this. This is a volvulus that you are seeing here. So remember that what you need to do here is emergency exploratory laparotomy with bowel resection is what needs to be done here, right? To preserve the bowel loops, we need to have a surgery being done. So emergency exploratory laparotomy with bowel resection is what needs to be done here. This is the whirlpool sign that you are seeing with the bowel dilatation that is seen here. Going to next question, 45-year-old patient with altered mental status and seizures. The findings are shown and what is the diagnosis? So if you look at the MRI here, T2 weighted MRI, there are these lesions in the splenium of the corpus callosum that you are seeing. This is the corpus callosum, the hyperintense lesions here. So the best answer here, it is going to be Marcia-Fava-Bignami disease, which is common in alcoholics and it commonly involves the corpus callosum. Okay, it involves the corpus callosum. Glioblastoma multiforme is going to be a lesion with peripheral nodular irregular enhancement, right? That can also involve the corpus callosum. Acute demyelinating lesion like multiple sclerosis will have the Dawson fingers appearance. CNS lymphoma is going to be more uniformly enhancing, particularly when you see the lesion involving the corpus callosum, the splenium of corpus callosum, you will think of Marcia-Fava-Bignami disease. So yes, that was about the radiology questions. I hope that's all clear. Thank you so much.
So now coming to the explanations of the anesthesia questions. Starting with the first question, guys. Match the patient scenario with the most appropriate immediate airway management. So there are 4 questions. Question A, B, C, and D, and 4 options are there. 1, 2, 3, 4. Question A. 28-year-old healthy patient with Mallampati class 1, normal neck mobility undergoing elective minor surgery. So basically a patient who's having a normal airway, Malampati 1 means all structures I am able to see, it means I can easily intubate this patient. I don't require any hi-fi procedure over here like video laryngoscopy or fiber optic and all. I'll just go for a direct laryngoscopy. Okay. So for question A, the answer would be option 2, that is standard direct laryngoscopy. Now we are left out with 3 answers and 3 questions. Okay. Now, 35-year-old overweight patient. He's not telling what exact is the BMI and all. He's having Malampati class 3 with limited neck extension and emergency appendectomy. He's posted for emergency appendectomy. We are assuming that it is a lap appendectomy. Okay. So for lap appendix, usually you go for general anesthesia. So now, if you are going for general anesthesia and all, you have to secure the airway. But this patient is having Malampati class 3 with limited neck extension. So what are the options that you are left out with? Rescue airway or LMA supreme insertion? No, I wouldn't go for it, because first I'll go for a intubation. If intubation fails, then I'll go for LMA or surgical cricothyrotomy. So this option 3 is not the answer over here. Can I go for a awake flexible bronchoscopic intubation? Again, guys, remember Malampati class 3 means you can try for an intubation. Why to go for awake fiber optic and all, right? So always remember, if he's having Malampati class 3, always you can go for a video laryngoscopy. Yani you are going with an intubation attempt with a video laryngoscope with adjuvant blades and other things you are keeping ready. So for question B, the answer is 2. Question C, a 45-year-old morbidly obese patient, Malampati 4, history of difficult airway, posted for emergency surgery. So this patient who is morbidly obese, having Malampati 4, you are just able to see the hard palate. You cannot see anything in that patient. You better go for an awake fiber optic intubation. Why? Because this patient is already having a history of difficult airway. Okay, so best option over here for this patient would be what, guys? Awake flexible bronchoscopic intubation or emergency video laryngoscopy can also be done over here. Okay, now question number 4 or question number D, 50-year-old patient who is in cannot intubate, cannot ventilate after multiple attempts. Yani ki basically we have tried video laryngoscopy, we have tried normal laryngoscopy, we have tried LMA and all. In that patient, what you can do is you can go for surgical cricothyrotomy. Basically rescue airway, LMA supreme insertion or surgical cricothyrotomy. Basically remember, guys, LMA already we have tried over here. In cannot intubate, cannot ventilate kind of scenario, LMA should not be tried because already we have tried. The answer should be over here what? Surgical cricothyrotomy. Surgical cricothyrotomy. This should be the answer. Why? Because cannot intubate, cannot ventilate. That is the only answer over here. So guys, the answer over here is what, guys? Basically it is, the answer is 2, 1. For C, what's the answer? 2, 1, 4, 3. Okay? So 2, 1, 4, 3. That's the answer. Right. Coming to the next question. Match the following anesthesia techniques with the most appropriate use or safety consideration. Option A, fascia iliaca block. First of all, guys, remember fascia iliaca block is used for what? It's basically a very low risk peripheral nerve block. It's a very low risk peripheral nerve block which is usually given for to provide analgesia for patient who's having any fracture of femur or fracture of hip. Okay? So when we try to match this, remember the first option over here is relative contraindication in coagulopathy due to spinal and epidural. No. Again, fascia iliaca has nothing to do with the spinal epidural. Fascia iliaca block is usually given where, guys? It is given below the fascia iliaca, and above the iliacus muscle, So it has nothing to do with the spinal or epidural. Okay? Next, it's a deep block. No, again, it's not a deep block. It's a peripheral neuroaxial block and it is very low risk. It's not a deeper. Okay? So option 3, Low risk of peripheral nerve block. Yes, it's a low risk peripheral nerve block. Provide analgesia in patients who are having severe COPD with minimal respiratory depression. Meaning what? It is not given for COPD patients. It is basically given for the patients who is posted for, who's having fracture of femur or fracture of hip and having COPD. It does not do anything. Basically, it provides no risk for any COPD patients and all. No respiratory depression risk. Okay. So, fascia-iliaca block, the answer is option 3. Next, question B. Spinal anesthesia with low dose bupivacaine. Okay. Now, we'll go with the first option. Relative contraindication in coagulopathy due to the risk of spinal and epidural hematoma. Yes, that could be the answer. Okay. We are just ruling out the right answers and all. We are just ruling out the answers. Okay. That could be the answers. Next. It provides a deeper block in neuraxial structures, high risk of bleeding in coagulopathy. No, it does not provide a deeper block in the neuraxial structure. It is basically an intrathecal block. Okay, so this couldn't be. Next, greater bleeding risk and hematoma than other peripheral blocks contraindicated in coagulopathy. Guys, remember, spinal anesthesia is contraindicated if the patient is having coagulopathy. But if you look at the other options, epidural is also given, spinal is also given. Guys, remember which anesthesia provides a much chance of bleeding, spinal or epidural? Always epidural. Why? Because if the patient is having coagulopathy and we put an epidural needle, which is a thick bore needle, then there are much chances of bleeding. Why? Because thick bore needle will cause much damage and all. Okay. So spinal won't cause this kind of greater bleeding and all. So that could not be the. Now we are left out with two options over here. Only one option. So spinal anesthesia with low dose bupivacaine, it is a relative contraindication in coagulopathy due to the risk of spinal hematoma. And if you are giving low dose bupivacaine, again the chances of hypotension are also low. Okay. So over here answer is 1. Next is what? Lumbar plexus block. Now we are left out with two options. Which two options? Option 2 and option 4. Lumbar plexus block. First of all, what is lumbar plexus block? Lumbar plexus block is also called as psoas compartment block. It is basically a peripheral nerve block which is given in the psoas major muscle. Okay. Now, when you are going with the lumbar plexus block with femoral plexus block, what are the two options that we are left out with, guys? Deep block near the neuraxial structures. Yes. Lumbar plexus block is a deeper block on the neuraxial structures and there is a high risk of bleeding in the patients who are having coagulopathy. Okay? That is lumbar plexus. Now what are we left out with? We are left out with epidural anesthesia. Epidural anesthesia, there is greater risk of bleeding and hematoma when compared to the other peripheral blocks, and epidural anesthesia is absolutely contraindicated if the patient is having coagulopathy or bleeding disorders or having a INR of more than 1.5. Okay. So basically the answers would be option A, 3, A3, B1, C2 and D4. Okay. So basically we have just done 2 questions, but this 2 questions means it's just not 2 questions, guys. 8 questions are there in this 2. Okay. So hope this was helpful, guys. Thank you.
Hello dear friends, this is Dr. Jambukesharan, PrepLadder's orthopedic faculty for you. Just we are going to see the answers for the INI-CET Champions Exam number 2, Ortho answers. We have 6 questions. All the questions are practically oriented questions, okay, of INI-CET type. We'll see the first question. A 35-year-old motorcyclist sustains a tibial shaft fracture. X-ray shows a comminuted fracture with 2 cm bone loss. Amount of bone loss is not very important in grading your, what I can say, compound fracture. And extensive soft tissue damage, this is very important. Wound size is 10 centimeters. That is very important. And there is devitalization of soft tissue. Soft tissue is dead. Okay. The injury occurred 6 hours ago and contaminated. These are the points. What is the Gustello-Anderson's classification it belongs to? What is the most appropriate management is the question. See, we all know Gustello-Anderson's type 1, type 2, type 3. Type 1 wound less than 1 centimeter, there is no devitalization of soft tissue. Okay, so it is not type 1. Type 2 wound more than 2 centimeter, less than 10 centimeters, there is no devitalization of soft tissue. So type 2 is ruled out. Type 3 is wound more than 10 centimeters, there is devitalization of soft tissue. So this should be a sort of type 3. Type 3 is subdivided into type 3A, type 3B, type 3C. Type 3A means adequate skin coverage is there. Type 3B means inadequate skin coverage is there. Type 3C is the most dangerous type, that is associated vascular injury. So here when I read this, only one type 3 which suits, it should be type 3A. It should be type 3A. Wound more than 10 centimeters, there is devitalization of soft tissue. That's all. 2 points are mentioned. So it's type 3A. And this has happened 6 hours before and it is highly contaminated. So immediately should not go for definitive procedure. So even though one type 3 is here, immediate intramedullary nailing will be a disaster. You can't do. The best option for this is wound debridement. First, clean the wound. Debridement means thoroughly cleaning the wound plus chopping away the dead tissue. So wound debridement, external fixation. Once the wound heals, the granulation forms and there is no signs of inflammation, there is no signs of infection, then we'll go for delayed internal fixation. So the right option should be answer A. Option should be answer A. We'll move on to the next question. A 25-year-old male falls from height, landing on his feet. He complains of severe low back pain. Neurological examination reveals motor weakness 4/5 in L3, L4 distribution. Sensation is preserved. There is brisk knee reflex. Okay, so it says CT scan is taken, shows a bust fracture here. Okay, so neurological deficit is there. It is an unstable fracture. It is an unstable fracture. Whenever there is neurological deficit is mentioned in your question, the treatment is surgery. You have to go for open reduction and through posterior and posterior stabilization. Open reduction and stabilization. This should be the right answer. We'll move on to the third question. Which type of proximal humerus fracture most often requires joint replacement? Proximal humerus fracture, the classification is called NEERS. NEERS type 1, type 2, type 3, type 4. Okay, so which needs shoulder replacement, joint replacement? Directly the answer should be type 4. This should be because highest chance of avascular necrosis. Highest chance of avascular necrosis. Shortly we will see what are the 4 parts. What are the 4 parts? Head, that is anatomical neck, is one part. Okay. Second is your greater tuberosity. Third is lesser tuberosity. Then it is your surgical neck. These are the 4 parts. Okay. You see here, one part fracture, it's the most common type, means fracture line involving one of 4 parts. No part is displaced. 2 part means fracture involves 2 of the 4 part, 1 part is displaced. This is 2. Okay. 3 part fracture means fracture line involves 3 of 4 parts, 2 parts are displaced. This is type 3. 4 part, all the parts are displaced. Okay. GT, LT, head and your surgical neck, all are displaced. Then it is 4 part. When it is 1 part fracture, K-wire fixation is the best management. 2 closed reduction, K-wire fixation. 2 part also you can try K-wire fixation. Okay. 3 part needs Phillows plating. Everything is there in our main video. Phillows plating. 4th is joint replacement. 4th is joint replacement because highest chance of avascular necrosis in this part. Okay. Yes. Right. We will move on to the next question. A 20-year-old saucer player sustains a knee injury during a pivoting motion. On examination, Latchman test is positive, pivot shift test is positive. This says that the patient has sustained anterior cruciate ligament injury. Okay. MRI finding shown below. That shows here, it shows, okay, ACL is torn. ACL is torn. What is the most appropriate? So, the best management for ACL rupture, ACL injury is reconstruction of the anterior cruciate ligament with Bone patellar tendon bone autograft with single bundle technique. This is the gold standard. This is the gold standard. Okay, hamstring autograft is allograft reconstruction, reduced donor site, all inside techniques, cortical button, all these are not the answer. The best reconstruction technique is bone patellar tendon bone autograft with single bundle technique. Okay, they will take semitendinosis, okay, or gracilis. Okay, so this is the best thing. Right, we'll move on to the next. A 12-year-old boy presents with hip pain after fall and he is unable to bear weight. 12 years, adolescent age group. Okay, X-ray shows physeal involvement. Okay, of the proximal femur. So what is the diagnosis? This is called slipped capital femoral epiphysis. Slipped capital femoral SUFI. Slipped upper capital femoral epiphysis. That is the slipped capital femoral epiphysis. That's the diagnosis. Best treatment, immediate treatment is admit him and do closed reduction under anesthesia with percutaneous pinning. This is the best treatment option among the four. Okay, so you are not supposed to do hip spica, observation, protected weight bearing and all. The slip has already happened because pain is there, unable to bear weight. Slip has already happened. X-ray showing that best thing is closed reduction under anesthesia with percutaneous pinning. Okay, that's the gold standard treatment. We'll move on to the next last question. A 25-year-old athlete presents with persistent wrist pain 3 months following a fall. So the injury has happened 3 months back. And scaphoid shows waist of scaphoid fracture with signs of non-union. That is, the edges are sclerosed. So this is non-union scaphoid and the duration is 3 months. What is the best treatment option? You can't do anything by closed method. Open reduction with vascularized bone graft. Open reduction with vascularized bone graft. This should be the correct option. Total wrist arthrodesis and all is the last resort, and for a 3 months old scaphoid fracture, we won't go for destructive procedures like that. Okay, so best thing is open reduction with vascularized bone graft. That completes the 6 questions. Thank you so much, dear friends.
So let's discuss the psychiatry questions of the Champions test. So let's talk about the first question. So in this question, a 28-year-old male is brought to the emergency department by the police after threatening neighbors with a knife. He appears markedly agitated, is responding to internal stimuli, and incoherently mentions voices commanding him to kill. His vitals are stable. There is no history of any substance use. The family reports a 2-week history of behavioral change. What is the most appropriate immediate intervention in this scenario? Options are A. Haloperidol 5 mg IM with lorazepam 2 mg IM. Option B. Risperidone 4 mg per oral with psychiatric consultation. Lithium 900 mg PO loading dose for acute mania. Or is it D. Clonazepam 2 mg PO for anxiety reduction? Now we can see that the patient is agitated. He is threatening the neighbors with a knife, and also the patient seems to be having certain hallucinations. Auditory hallucination is present. So it seems to be a case of acute psychosis, as they also mentioned the duration to be 2 weeks. So what is the management of agitation in this scenario? Now, agitation due to a primary psychiatric illness. So interventions we can remember, it is in a hierarchical manner. So initially, when we manage such patients' agitation, we begin with least restrictive and least intrusive interventions. So we initially try to decrease agitation using psychotherapeutic processes. So use of interpersonal strategies that emphasize verbal de-escalation intervention techniques. So such techniques can be used. So many times we see that by using these therapies, so we are trying to talk down the patient. So we are using psychotherapeutic processes to manage agitation. If that doesn't work, sometimes the patient may not respond to or only partially respond to verbal intervention. So in those scenarios, we can use psychotropic medication. So then we can use certain chemical agents, that is medicines, to decrease the agitation. Now, when these less restrictive interventions, they fail, then physical restraints can be used. But remember, they are used only, when there is imminent harm to the patient or to others. So to prevent that harm, we can also use physical restraint. So remember, it is one of the last resort we use for managing agitation. So we first try to talk down the patient, then we may use chemical restraints in the form of medication, and lastly, we may use physical restraint. Now coming to the medications, the first line intervention for agitation, again here also we initially prefer oral drugs. So we can use oral disintegrating or liquid risperidone 2 milligram. So 1 to 2 milligram, this is the initial dose which can be used. Or we can also use orally disintegrating olanzapine 5 to 10 milligram. Now oral benzodiazepines, these can be added if deemed necessary and should be done so before adding additional antipsychotic dose. So initially we can begin the oral medication, and if required we can also add benzodiazepine, and if further antipsychotic doses may be required, then we can increase the dosage. So again, this is a very important point to remember. For severe agitation secondary to psychosis, when the oral medication they are not responding, or oral medication may not be possible at times, so then we can use IM ziprasidone 20 milligram that can be supplemented with IM lorazepam 2 milligram, which is the first line management. And we are giving lorazepam to limit the potential side effects which can occur with antipsychotic. Also, second line recommendations are IM haloperidol 5 milligram and IM lorazepam 2 milligram, or even IM olanzapine 5 to 10 milligram can be used. So again, we can combine haloperidol and lorazepam, and also we can give only olanzapine. Remember, lorazepam should not be used in combination with olanzapine. Why? Because of risk of cardiorespiratory depression. Now coming to this scenario, so again, we can rule out two options, that is lithium. Again, it does not seem to be and also we will not use lithium for managing agitation here, and also clonazepam may not be that much useful to decrease the agitation. So risperidone oral medication would have been preferred, but here they have mentioned 4 milligram. So we have discussed initially we'll start with 1 to 2 milligram. We can add benzodiazepine, and if further required, we can also increase the dose. So here the correct answer is option A, that is haloperidol 5 milligram IM with lorazepam 2 milligram IM. Let's discuss the next question. Now the question is that a 30-year-old male is brought to emergency department with agitation, hyperthermia, the temperature is 40 degrees centigrades, there is dilated pupils, profuse sweating is there, his heart rate is 150 beats per minute, and his blood pressure, again it is increased 180 by 100 millimeter of mercury. He admits to use of cocaine 2 hours ago. So there is recent use of cocaine has been there 2 hours back. His urine toxicology is positive for both cocaine and alcohol. What is the most appropriate immediate management? Options are A, haloperidol 5 milligram IM for agitation control, B, lorazepam 2 to 4 milligram IV with cooling measures, beta blocker propranolol for hypertension and tachycardia, or naloxone 0.4 milligram IV to reverse potential opioid intoxication. Again, we know it is not a case of opioid intoxication. Now, how to manage this patient? Again, we can see that this patient seems to be having cocaine intoxication. So patient is having symptoms of tachycardia, there is increased sweating. All those symptoms we have discussed can occur with cocaine intoxication. Now, coming to the treatment, remember, no specific pharmacological treatment is there for cocaine intoxication, and supportive care is the mainstay of the management. Most patients will recover spontaneously, maybe in hours to days without need of pharmacological therapy. And stimulant intoxication, it can be complicated by some of the other features such as paranoia can occur, agitation can occur, even seizures can occur, hypertension and its sequelae can occur, and even end organ ischemia can occur. Now coming to agitation or paranoia, when it occurs, it may require intensive monitoring in a controlled setting, and also short-term treatment may be required in the form of benzodiazepines. So benzodiazepines can be used. Again, benzodiazepines may also take care of some of the effects such as seizures which may occur, and also sometimes antipsychotic medication can be used. So supportive care is important, and if there is agitation, we need to decrease agitation, and subsequently certain other management depending on the symptoms we can manage. So in this scenario, again, you can see we can use lorazepam 2 milligram to 4 milligram IV with cooling measures. So again, certain supportive measures can be used. So we can give lorazepam in this scenario. Also, you can see here the patient's urine toxicology is positive even for alcohol. Sometimes we see that patients consuming cocaine may also additionally use other substances such as alcohol, and alcohol can be detected if taken, can be detected 12 hours after the intake. So here we can see it seems to be a case of cocaine intoxication. Lorazepam may also be useful if there are any alcohol withdrawal symptom present in the patient. So here the answer is lorazepam, and along with this we can use other methods such as cooling measures. So depending on whatever symptoms patient is having, we can give supportive management in the patient. Let's discuss the next question. A 28-year-old man presents with a 1-week history of elevated mood, increased energy, decreased need for sleep, excessive talkativeness, and impulsive behavior. He also has a history of major depressive episode lasting for 3 weeks. What is the most likely diagnosis? Options are A, major depressive disorder, B, bipolar 1 disorder, C, bipolar 2 disorder, or is it D, cyclothymic disorder? Now this question, I would say, in fact, two options seem to be very similar and could be the answer. So here we know that it is not cyclothymia. In cyclothymia, we know that the patient has mild depressive symptoms and mild symptoms of mania which are present for 2 years duration, and the patient is not having any episode of MDD or any episode of mania. And we know also it is not just major depressive disorder. So because patient earlier had an episode of depression, now patient has an episode of which could be of mania or hypomania. Then what is the answer? Again, in this scenario, I would say both B and C could be the answer. So let's discuss this scenario. So we know bipolar 1 disorder, if a patient has at least one episode of mania and at least one episode of depression, and even we know even if a patient has only episode of mania, then also we consider it as bipolar 1 disorder. While when we talk about bipolar 2 disorder, there is at least one episode of hypomania and at least one episode of depression. Now we know what are the symptoms of mania, how to make a diagnosis of mania. So let's discuss. We know the mnemonic me, dig, fast. So this is the mnemonic we remember for all symptoms of mania. M is mood. Mood is either elevated, there is elation of mood, or sometimes the person mood is irritable. E is energy. The energy levels are increased. D is distractibility. I is patient may have impulsivity. And G is grandiosity or inflated self-esteem. F is flight of ideas. A is activity levels are increased. S is sleep. There is decreased need for sleep. And T is talkativeness. Now to make the diagnosis of mania, we know that both 1 and 2, both these symptoms are present, and along with this 3 or more symptoms are present. If the patient's mood is elated, then we say 3 or more symptoms. But if the patient has irritable mood, remember, then we say 4 or more symptoms should be present. And what is the duration? The duration is 1 week. Then we make a diagnosis of mania. And how do we make a diagnosis of hypomania? Remember, hypo is telling us that the symptoms are similar to mania, but the severity is less. So they are not severe enough to cause marked impairment of social or occupational functioning. So one of the important differences is that in mania, there is impairment of functioning, while there may not be that much marked impairment of functioning in hypomania. And what is the duration for hypomania? Remember, the symptoms should be present for at least 4 days. Again, how to differentiate mania from hypomania? One is, we know that functional impairment is not very severe. Also, remember that in hypomania, patient will not have psychotic symptoms. Sometimes patient with mania may also have psychotic symptoms like delusions, hallucination. Then we make a diagnosis of mania with psychotic symptoms. So if psychotic symptoms are present, then we will call it as mania with psychotic symptom and not hypomania. Also in hypomania, there is no need for hospitalization. So if there is a need for hospitalization, then also we'll make a diagnosis of mania. And also usually we see that flight of ideas is usually not seen in hypomania. So these are important points to differentiate mania from hypomania. Now coming to this, as we can see that the symptoms could be for mania as well as for hypomania. So yes, you can consider it as bipolar 1 and even bipolar 2 disorder. But again, if you have to choose one answer, then we can go with bipolar 1 disorder. But again, yes, I would say that it's difficult in this scenario to differentiate it from mania from hypomania. Now let's talk about the next question. A 17-year-old female presents with 6 months history of restrictive eating, 25-pound weight loss, and amenorrhea. BMI is 16.5 kg per meter square. She denies binging or purging and is preoccupied with body image and fear of weight gain. Determine the most appropriate initial treatment approach. Options are A, immediate inpatient psychiatric hospitalization, B, outpatient family-based therapy moduli approach, C, individual cognitive behavioral therapy for eating disorders, or is it D, nutritional rehabilitation with dietitian consultation only? So we know what is the diagnosis here. The diagnosis here is anorexia nervosa. as we can see that patient is having decreased intake of food, the BMI, the weight is reduced, very important for making a diagnosis of anorexia. Body image, she's preoccupied with body image and fear of weight gain. Now again, remember in anorexia nervosa, we know that the weight of the BMI is reduced than normal. It's a very important criteria to make the diagnosis. Now talking about the management, now before the treatment, also remember the age, very important. The age is 17 years. So when we talk about the treatment, the primary treatment goal is nutrition rehabilitation and weight restoration. And many times we may have to admit the patient, and some of the indications of admission is when there is any complication such as dehydration or there is electrolyte imbalance. Sometimes also when the weight, or you can say BMI, in adolescents we say when the BMI, it is reduced by 75% of the median BMI for weight and gender, that is sex. So it is reduced by, decreased by 75% of the median as per the age and the sex of the patient, then we can even admit. Now, in the management, remember, psychotherapy we can use CBT, which is most extensively studied and utilized treatment, but it is for adults. Now, talking about for children and adolescents, family-based therapies have found to be useful. One of the method is Maudsley method. It has demonstrated effectiveness. Here, what we do is that the parents, they take on the responsibility of refeeding their child with the therapist coaching and support. Sometimes family-based intervention, especially for adolescents, for children, we can use this method. Also, Maudsley anorexia treatment for adults, that is mantra, that targets interpersonal factors among other things, that is also showing promises. So even Maudsley's approach, anorexia treatment for adults has also been studied and it is showing promise even in the adults. So remember, for children or adolescents, we can use Maudsley method. So here, coming to the answer, immediate inpatient psychiatric hospitalization may not be required because indication is not such. Nutritional rehabilitation with dietitian consultation only is also not the only treatment. We would also like to have psychiatric consultation, would like to start the patient on therapy. So here, since the child is in adolescent age, the answer here is outpatient family-based therapy, that is Maudsley approach. Also, we know that certain drugs can be used, like SSRIs have found to be useful in the patient, and also antipsychotic olanzapine has shown promise in promoting weight gain and reducing distressing psychological symptoms in anorexia nervosa. Let's discuss the next question. A 30-year-old pregnant woman at 8 weeks of gestation with a history of bipolar disorder, so the diagnosis is bipolar disorder, presents with a manic episode. She is currently taking lithium 900 mg twice daily with serum levels in the therapeutic range. So she is taking lithium despite in the therapeutic range, she is now having a manic episode. What is the most appropriate adjustment to her medication management? Options are A, continue lithium with increased monitoring and dose adjustment. B, discontinue lithium and initiate quetiapine 300 mg daily. C, switch to valproate 5 mg BID with folate supplementation. Or is it D, add risperidone 2 mg daily to lithium therapy. Now, when we talk about the management of bipolar disorder in pregnancy, we have discussed this, that antipsychotics are preferred relatively, they are one of the safest and not much teratogenic effect is seen. If antipsychotics may not be used or, they're not showing a response, then lithium can be used. But remember, lithium has teratogenic effect and it can cause Abstin anomaly, which is a tricuspid valve defect. The risk, although is low, it is 1:1000. And if we are giving a female who is pregnant, we are giving lithium, so we have to do USG fetal echocardiogram. It should be done. Valproate generally should be avoided in pregnancy because again, we know that neural tube defect can occur. And if the female is to take valproate in pregnancy, then at least 1 month before conception, a folate supplementation should be done. And also remember, valproate can also affect the cognitive development and low IQs. If possible, we may try to avoid valproate in pregnancy. Now, coming to the treatment of bipolar disorder in pregnancy, NICE guidelines, they recommend that if a woman who is taking lithium becomes pregnant and she is doing well, so what can be done? Consider stopping lithium gradually over 4 weeks and explain that there is a risk of relapse. So yes, we know that if we continue the medication, risk of relapse is there. So explain it to the patient, to the family members, and also particularly in the postnatal period if she has bipolar disorder. This is when the patient is doing well. Now, if woman is taking lithium, she becomes pregnant and is not well or at high risk of relapse. As in this scenario, she develops a manic episode. So consider switching gradually to antipsychotic or stopping lithium and restarting it in second trimester. If the woman is not planning to breastfeed and her symptoms have responded better to lithium than to other medication in the past, or continuing with lithium if she is at risk of relapse and antipsychotic is unlikely to be effective. So it means we would initially try to stop lithium and we can switch to antipsychotic. And if antipsychotic not working, then we may consider continuing a lithium, but we have to again explain the risk of continuing lithium in pregnancy. Now, if lithium is considered essential in a woman planning pregnancy, so if lithium is to be given because of her condition, then women should be informed of the risk of the fetal heart malformations when lithium is taken in the first trimester, and also risk of toxicity in the baby if lithium is continued during the breastfeeding period. So all these things should be explained to the patient. So in this scenario, we can see what we can do is we can discontinue lithium and initiate quetiapine, which is antipsychotic, second generation antipsychotic in this scenario. Of course, we will not switch to valproate in this scenario. Valproate, if possible, we would avoid in pregnancy. Let's talk about the next question. A 30-year-old female patient with treatment-resistant schizophrenia has started on clozapine. So we know treatment-resistant schizophrenia if there is no response to at least 2 antipsychotics. So clozapine is started. What is the appropriate duration and frequency of blood test monitoring for this patient taking clozapine? So option is A, weekly for 6 months, then bi-weekly for 6 months, then monthly. B is monthly for 6 months, then every 3 months. C, weekly for 3 months, bi-weekly for 3 months, then monthly. Or is it D, monthly for a year, then every 6 months? So we have discussed some of the serious side effects with clozapine with the mnemonic SAM. SS seizures can occur especially at a higher dose. So they are dose dependent, especially if the dose is more than 600 milligram per day. If seizures occur, then we may also have to start an anti-epileptic drug. A very important serious side effect is agranulocytosis, decrease in the absolute neutrophil count or the WBC count. Now, when a person has developed agranulocytosis, then we have to stop the medication. Now, this is such a serious side effect that when we are giving clozapine, we monitor the counts weekly for first 6 months. So for first 6 months, every week we will check the count. Then every 2 weeks for the next 6 months. So the next 6 months we will do it every 2 weeks. And after that we will do it monthly. And we will stop if the WBC count is less than 300 millimeter cube or a absolute neutrophil count is less than 1500 millimeter cube. And M is myocarditis. So patient on clozapine may present with chest pain, there is abnormal ECG, tachycardia, then again we have to stop clozapine. So in this scenario, how frequently we will monitor the count? Remember, weekly for 6 months, then we'll do it bi-weekly for 6 months, and then we'll do it monthly. So these were the psychiatry questions. Again, thank you, and keep your preparation, at a good level, and keep smiling, keep moving forward, take one day at a time, and everything will be well.
Hello students, so today I'll be discussing the dermatology questions. Coming to the first question, assertion A, carbamazepine can cause Stevens-Johnson and toxic epidermal necrolysis. The reaction is mediated by a drug-specific immune response leading to widespread keratinocyte necrosis. Now, are these options correct? Now, let's look at the option A. We all know that yes, all anticonvulsants including carbamazepine can cause SJS-N10. And how does it causes? Basically, SJS-N10 are mediated by drugs. So they are caused by drugs. So it is mediated by drug-specific immune response, CD8 cytotoxic T cells are stimulated, and this leads to widespread keratinocyte apoptosis leading to epidermal necrolysis. And so this is a correct explanation of option A. So both A and R are true, and R is the correct explanation of option A. So this is because SJS-10 They may be triggered by infection, but most likely they are caused by drugs, and these drugs, they induce specific immune response, which leads to keratinocyte apoptosis, which eventually leads to epidermal necrolysis. So both A and R are true. Let's look at the second question. A 70-year-old male presents with tense bullae involving flexural areas and trunk. So old age, tense bullae, flexural area and trunks, we are more or less sure that we are dealing with the subepidermal immunobullous disorder. Skin biopsy with DIF shows linear IgG and C3 deposition. ELISA reveals positive antibodies against BP 180 and 230. So all of this is pointing towards a diagnosis of bullous pemphigoid. Now when we have tense bullae on flexurals and trunk, IgG and C3 linear deposition with positive BP 180 and 230, this is bullous pemphigoid. Now the question is, what is the most appropriate first line systemic therapy? Now in bullous pemphigoid, let's look at the options. Prednisolone, rituximab, dapsone or methotrexate. So we all know that dapsone is my initial drug of choice for patients of bullous pemphigoid. Had it been pemphigus, then my choice would have been prednisolone with a steroid sparing agent. But here, dapsone would be the best choice. Rituximab is also used in immunobullous disorder, but that's not usually the first line of treatment. That is usually used when the conventional drugs fail. Right? So here the answer would be option C. Match the organism with its causes. So let's see, Trichophyton rubrum. We all know Trichophyton, Epidermophyton and Microsporum. These are causes of dermatophytosis. So Trichophyton rubrum causes dermatophytosis like Tinea corporis and pedis. What does Horte wernicki causes? Horte wernicki is the causative agent for Tinea nigra, leading to hyperpigmented asymptomatic round patch on the palm. Candida albicans can cause a lot of infections, but here it matches with this option 3 where it says that it causes intertrigo and mucocutaneous infection. Malassezia furfur, we all know, causes pityriasis versicolor. So the correct answer would be option A. Right? A 50-year-old fair-skinned male patient presents with changing pigmented lesion on his back. Dermoscopy reveals atypical features. So I have an image, a pigmented patch, and dermoscopy is showing atypical features. Histopathology is also showing a Breslow thickness of 2.1 mm, ulceration and a high mitotic rate. So all of these is pointing towards malignant melanoma. Now, what do you do in malignant melanoma? So, whenever we are suspecting malignant melanoma, we do a staging. How do we stage it? We first do a sentinel node biopsy followed by imaging of various organs. So, let's look at the options. So, A option is sentinel lymph node biopsy only. B, CT chest, abdomen, pelvis with PET scan. C, sentinel lymph node biopsy with baseline imaging, and D, MRI and complete blood count. So out of this, I think the best option should be C, because in the staging workup, first is sentinel lymph node biopsy, which is followed by imaging of various organs. So now, since option A says only, I don't think so that should be marked as the correct answer. So my best answer would be sentinel lymph node biopsy with baseline imaging. Next question, a 35-year-old male presents with moderate to severe plaque psoriasis affecting more than 10% of body surface area. PASI is also more than 10, necessitating systemic treatment. So more than 10% body surface area, more than 10 PASI, we know we have to give systemic treatment. He has already failed topical therapies and even phototherapy. There is no contraindication to systemic therapy. What is the most appropriate next treatment option? So when we have a patient of psoriasis vulgaris, not responding to topicals, not responding to phototherapy, we have to give oral agents. And if it is a case of psoriasis vulgaris, as is quite evident in the image, we see erythematous scaly plaques. So this is psoriasis vulgaris. So my treatment of choice is oral methotrexate. So here my answer should be oral methotrexate with folic acid supplementation. Adalimumab is a TNF-alpha inhibitor and it is a biological which is used in psoriasis but will not be my first line of agent. Cyclosporin in divided doses is used in severe psoriasis. Here the body surface area is 15%. I do not see any pustules. So it is used as a crisis drug. So I'll not make it my first line treatment. Oral corticosteroids are never to be given in psoriasis. So here my answer would be option A, oral methotrexate. A 42-year-old female presents with scarring, hair loss over scalp, painful oral erosions and nail changes. So I have nail findings, scarring alopecia, painful oral erosions and DIF which shows linear IgG deposits along the basement membrane zone. What is the most likely diagnosis? So what fits best into this clinical scenario? So let's look at the option. Obviously lichen planus. We know lichen planus can affect skin, hair, nails and mucosa. In DIF, you can see linear IgG deposits. Let's look at the other options. Psoriasis does not lead to scarring, hair fall or painful oral erosions. Pemphigus, again, no scarring, hair loss, no nail changes. And DIF will not show linear IgG deposits. Alopecia areata is a cause of non-scarring alopecia. So here my answer would be lichen planus. That's it. Thank you so much.